Welcome you all. Start the mic. हाँ. Okay. 9:15 होने वाला है. Candidate.
Good morning, everyone. Hello. Hello. Good morning, everyone. I welcome you all on day 3 of Mini IOACON 2020 held in Jaipur. Today is the last day, and we will progress with our free paper sessions. I request Dr. Anurag Dhakad to chair the session.
Thank you.
Thank you. And sir, please, if you may, request the first speaker to come on the dais and start.
So I request Dr. Dipesh Kumar, please come on the dais and present your paper. Before that, I welcome you all people who are here to attend the session. And I request the speaker that adhere to the time limit.
Thank you, sir. Good morning, Chairperson, my seniors and my colleagues. Today I'm going to present my paper named Conservative Acetabular Reconstruction in Total Hip. Our experience. To begin with the introduction. Hello. Hello. As we all know that number of total hip replacements are increasing day by day. And the reason behind it may be because of the patient awareness, surgical skills and the experience that surgeons are getting. And moreover is the different methods that are present at present. So to begin with the introduction, total hip replacement are in vogue in this part of the world for a quite long time. So number of revisions are increasing day by day. And the reason behind it is, which causes further is the progressive destruction of acetabular socket following total hip replacement, especially with the metallic cause, is the known problem in the patients with acetabular defect. And the reason behind is most of the acetabular defects are usually managed with several ways and cases, which might make bone weaker and fragile, and the revisions might be difficult in the future case. So the main aim of our study was to study the overall outcome of the various types of acetabular defect managed by a bone graft. Regarding materials and methods, it was a case series prospective study. Number of cases were 10. Mean age was 41 to 80 years, and duration of study was of 3 years. While in inclusion criteria, all types of acetabular bone defect requiring separate management planning, where we used a Peprosky classification for acetabular defect. Regarding the approach, it was a posterolateral approach, and follow-up was minimum of 6 months to maximum of 3 years. We all are well known with this Peprosky classification, where in type 1, there is a mild cancellous bony defect, while in type 2, there is a moderate, which involves more than 50% of the bone loss. And in type 3, there is a severe, according to type 3A and 3B. I would like to share some cases which we did. This was a case of Peprosky type 3A. This is the X-ray report. We did a CT and we planned for a acetabular reconstruction along with the total hip replacement. This was a intraoperative image where we can see a huge large defect present at the acetabulum. We prepared the acetabulum. We filled the defect with a femoral head as a bone graft and fixed with a screw and did a total hip replacement. This was a follow-up at 6 months follow-up, at 1 year, at 2 year and 3 years follow-up. This was another case of Peprosky type 2V, where there was a protesia of the femoral head of the implant along with the periprosthetic fracture. We planned for a implant removal and planned for a filled with the plan to fill with the acetabular defect with a bone graft from the iliac crest and fixed with a plate and screw and did a total hip replacement. This was an intraoperative image where we can see the
Please.
defect was filled with
Hello.
not functioning, sir.
You continue. The
With
mic
plate,
is not working.
it's not functioning. These are the follow-up image at 6 months, 1 year follow-up, and 2 year follow-up. This was another example of Peprosky type 2C, where we can see a huge loss of bone. We planned for a total hip replacement along with acetabular defect, filling with a bone graft from the iliac crest. These are the intraoperative image where we filled the graft, put the graft and fixed with a plate and a screw. These are the follow-up image. Another was a type 3A, where he had a surgery 4 years back, but later he came with a complaint of severe hip pain. We planned for a resurgery. We removed the implant and did a total hip replacement with a bone defect filled with a graft and fixed with a plate. These are the follow-up image at 6 months and 1 year follow-up. This was another case where he had a surgery 9 years back. Later he had a dislocation. We planned for a revision. We did remove the implant and fixed with a bone graft for the defect and a total hip replacement was done. These are the follow-ups at 6 months, 1 year, 2 year, and 3 years follow-up. So regarding the result, in all cases, the bone graft held both clinically and radiographically over the period of time. There was no sign of loosening of the cups, nor there was any dislocation of a graft or a cup occurred, and all patients' bone graft held and osteointegration of the cup was optimum. From the discussion point of view, this was a paper published in 2012, where they did impaction bone grafting along with a total hip replacement in a 24 cases, where they had excellent result in a minimum of 5-year follow-up in a 23 cases. This was another paper published in 2011, where they did impaction bone grafting in extensive acetabular defect and did a total hip replacement, and they got a excellent result of 91.6% in a minimum of 5-year follow-up. This was another paper in 2006 where they did cementless acetabular reconstruction with a structural bone grafting in dysplastic hip, and a minimum follow-up. They had a minimum follow-up of 10 years and had excellent result. Further in a discussion, as management protocol in managing bone defect was well defined as per Peprosky classification, but mostly these days they are managed by use of some sort of metal augments, which replaces the native acetabular bone with the metal augments, and hence in the revision scenario, this makes reconstruction more difficult. So it is always preferred to have some bone preserved and reconstructed in the acetabulum. So to conclude, as life expectancy is increasing day by day, and more younger patients are getting hip replaced, and revision and re-revision scenario are only going to increase in our practice. So conservative acetabular reconstruction, that is reconstruction of a bone defect with a bone graft, should be the first priority whenever it is feasible. Thank you for your patience.
Okay. Well presented, Dr. Dipesh. And any questions from the audience? It's a good. I want to ask one, which approach you preferred in these cases?
In all cases, we went through posterior lateral approach.
Posterior lateral approach. Okay. And what was your weight bearing protocol?
We started weight bearing according to the size of the defect of the bone graft. Minimum we started within 6 to 12 weeks of the toe touch, and as according to the is pain
And
tolerance.
without weight bearing, you started ambulation?
Yeah, we started ambulation from first to second weeks of
As you presented in a paper, these such techniques can be had been already used in the dysplastic hip. Have you included those cases in your studies?
no, sir.
Okay. So it was nice presentation.
Thank you, sir.
Thank you.
Thanks.
Now I call Dr. Shrikant M. Kumar Pandya. Evaluation of clinical outcome after medial open wedge high tibial osteotomy with Tomofix.
Good morning. My name is Dr. Shrikant. I'm a second year resident of Hospital, Ambala, Haryana. My presentation is on evaluation of clinical outcome of medial open wedge high tibial osteotomy with Tomofix fixation without bone substitute for medial compartment osteoarthritis of knee. Opening wedge high tibial osteotomy is a reasonable treatment for unicompartmental medial osteoarthritis with varus deformities in active patients. It improves transfer of load from medial to lateral compartments, relieving symptoms, increasing healing of the damaged cartilage, and slowing the progression of arthrosis. The mechanical axis extends from the center of femur head to the center of ankle mortise. It is 0 to 2.2 degree valgus to the vertical axis. The anatomical axis is in line with the diaphysis of the shaft. It is 5 to 7 degree valgus to the vertical axis owing to the wide separation of the hip joints. The normal mechanical axis extends through the medial tibial spine, but in a valgus knee it extends laterally, and in a varus knee it extends medial to the medial tibial spine. There have been countless papers on the efficacy of high tibial osteotomy, and almost all of them agree that valgus high tibial osteotomy reduces pain, improves knee function in patients with medial compartmental osteoarthritis of the knee. The aim of our study is to know functional and radiological outcome of medial open wedge high tibial osteotomy and to determine the predictors of outcome. Clinical presentation, the average age of our patients was 55, youngest being 49 and oldest being 71. However, age was no bar. Although in most patients, knee was painful medially, maximum pain was also on weight bearing was also seen on lateral ankle on 4 patients, lateral side of knee and thigh in 8 patients, and pain on medial side on knee flexion. Patients with ankle pain were subjected to ankle MRI and were found to have grade 1 anterior talofibular ligament requiring no intervention. 18 patients were studied with 20 knees. 2 patients had bilateral knees who were operated in a gap of 2 months. Radiological documentation was done. Weight bearing line was found using scanogram. Patients having only patients included were having changes limited to medial compartment up to all back grade 3 without major articular cartilage or ligamentous damage as confirmed with MRI. Patients excluded were patients with more than 15-degree contracture, joint instability. If more than 20-degree correction was required, rheumatoid, inflammatory, or advanced patellofemoral arthritis were excluded. Planning standing scanograms in neutral rotation were done, and mechanical and anatomical axis was measured. For planning post-operatively, the weight-bearing line must pass 62.5% across tibial plateau from the medial side to create an overcorrection of 3 to 5 degrees above the already normal 6 to 7 normal valgus angle. This was the Fujisawa point, which was introduced by Fujisawa et al. In 1979, who suggested that mechanical axis passing the lateral tibial plateau at 62% gives the best result. At surgical technique, a lower limb was kept 40-degree flexed on a pillow and a single anteromedial vertical straight incision extending from joint line down medially towards the tibial crest. Following the incision, the edge of pes ancerennis was identified, retracted. The superficial part of medial collateral ligament was released. Patellar tendon identified and retracted. After passing the guide wires, the first oblique osteotomy made medial to lateral towards the tip of the fibular head, and the second proximal. If the correction is required is less than 12 mm, second osteotomy proximal to the tibial tuberosity And if the correction required is more than 12 mm, distal to the distal biplanar osteotomy is made. Correction is done as desired by putting the alignment rod, and tomofix plate fixation was done. There was no bone graft substitute used. Post-operatively, patient was started on continuous passive motion of the knee, isometric quadriceps strengthening immediately after surgery. Up till first 3 weeks, partial toe touch weight bearing was done, which was progressed to full weight bearing over 3 to 6 weeks as tolerated. Active knee movement was encouraged. Patients were reviewed monthly till signs of union were seen radiologically. Clinical assessment was done using Knee Society objective and functional score. Results: full weight bearing was achieved at a mean of 9 weeks. 50% obliteration of gap was observed with gap healing time 4 months. Mean femoral tibial angle at final follow-up was 10.3 degree valgus. There was no delay in union. All were satisfied and were walking without aid at 2 years follow-up. This is the pre and the post-op Knee Society score, which showed improvement in both objective and functional score. There was only one complication, superficial wound infection, which was resolved with oral antibiotics. There are few case examples. This is the pre and post-op X-rays. Patient had good function of the knee joint, and another patient with pre and post-op scanograms, which showed with good functional knee arm. Conclusion: medial opening wedge high tibial osteotomy can be performed without grafting. Early weight bearing can occur without risk of non-union or loss of correction. Functional results showed that patients were satisfied with the procedures, and bone graft substitute do not change the ultimate outcome of osteotomy. Thank you.
Thanks, Dr. Shrikant. And any questions from the audiences?
You did pre-operative MRI in all your patients. Do you think it is a necessary investigation to do before HTO?
If they have, if they're showing signs of instability, then sure. But we had excluded that patients.
No, MRI, how will it show signs of instability?
Right, to understand the ligamentous integrity. Yes, we did do it and all.
That can be done with clinical examination.
Yes, but also the articular integrity has to be known. We can see that through X-rays.
All
also.
medial compartmental will have cartilage damage. That's why they are having osteoarthritis. So in my understanding, MRI is not necessarily required in all these patients. If you are doing it for a study purpose, that is different.
Yes,
but in actual practice, X-ray alone are enough in my understanding. If you have any indication for MRI, you can please elaborate.
Dr. Amit, nowadays the advanced MRI version, it in such type of cases, what he presented, it requires to assess the early dehydration of the cartilage, which cannot be assessed by the routine MRI we are doing. So that may be an indication, but that is a separate issue of study. Number one. Number two, I'm asking one question. Were there any neurovascular issues in your cases?
No, sir. Post-operatively?
Yeah.
None, sir.
No. Then you said age is no bar in your study.
Yes.
But specificity of what you assessed from your study in different age group, because the density and all things differs with all physiology of bone, differs with the age group. If
Yes.
each decade we study.
Yes, sir.
So how you can compare? And it is not a comparative study.
No, sir. It was a,
You said because you, what is the logic of this study? You just opened a space without putting any bone graft.
Yes.
You left the healing by applying a mechanical bridge. So I wanted to ask if bone graft already has not been used in your cases, how you can compare that it is superior than the applying the bone graft? It is just I am asking.
Yes, sir. That's true. Basically, there was patient was started on weight bearing, and there was no loss of correction. It's not a comparative study. It's an
Observational study.
Observational study.
Okay.
And yes, sir.
Okay. Thanks. So, any other question? No. Now, I'm inviting Dr. Isparsh Singh. A comparison of hematological outcomes with or without a pneumatic tourniquet in primary total knee arthroplasty.
Good morning, sir.
Yeah, good morning.
I'll be presenting a comparison of hematological outcomes with and without a pneumatic tourniquet in primary total knee arthroplasty. Total joint arthroplasty is frequently done procedure in modern day practice of any orthopedics unit. Reducing blood loss both post-operatively and intraoperatively presents a challenge to the surgeon. Total joint arthroplasty has traditionally been carried out with the use of tourniquet placed in proximal thigh position. Benefits of using tourniquet are improved visualization of structures, reduced intraoperative bleeding, better cementation, reduction in operative time by allowing the surgeon a bloodless operative field. It also it is also thought to improve the cementing technique during prosthetic implantation, as the bloodless field permits better penetration of the cement into the bone. However, these presumptions have been questioned. There is an increased body of evidence that tourniquet use may be of no benefit and perhaps cause harm. Improved pain scores when a tourniquet has not been used have been documented. This is presumed to be due to lack of ischemic injury to the limb as well as crush injury to the musculature. There is also recent evidence that when a tourniquet is not used, the quadricep musculature maintains a greater degree of strength and the knee has better range of motion. These factors can all improve patient recovery. Materials and methods. Type of study was prospective randomized control trial. Total number of patients was 60 who underwent a primary total knee replacement arthroplasty. Center of study was Eras Lucknow Medical College. Duration of study was between 2016 December to August 2018. 30 patients were operated on which the use of tourniquet was done on group A, and 30 patients without the use of tourniquet in group B. Exclusion criteria: patients with coagulation disorder, previous thromboembolism, previous open knee surgery, and bilateral joint arthroplasty were excluded from the from the study. Randomization of patient was made by placing even and odd values in a computer generated table, and neither the patient, physiotherapist, nor the nurses were informed as to whether or not the tourniquet was used. In group A, the limb was first exsanguinated by elevation for 3 minutes. Then the tourniquet was inflated to 125 mm Hg above systolic pressure. If if the duration of tourniquet exceeded 90 minutes, the tourniquet was released intraoperatively and hemostatic was completed. After 10 minutes of release, a new exsanguination was instituted. The tourniquet was deflated after the bone cement had set, and only then the electrocautery was used for hemostasis. In the non-tourniquet group, electrocautery was used as necessary throughout the procedure. All the operations were performed under combined epidural and spinal anesthesia. Surgical procedure was performed through a medial parapatellar approach, followed by eversion and lateral dislocation of the patella, resection of the menisci and anterior cruciate ligament, femoral and tibial cuts according to the standardized technique of the knee arthroplasties. Femoral cuts were performed with intramedullary guide and tibial with the extramedullary guide. All prostheses were cemented and femoral orifice obliterated with bone graft. Ceftriaxone 1 gram was given IV at induction of anesthesia. Two further doses of 1 gram were given post-operatively at 12-hour interval. For anticoagulation, prophylaxis calf pumps were used in all patients. In all patients, a posterior stabilized prosthesis were used and patella was not resurfaced in all cases. Negative suction drains were inserted before the closure. After closure, the knee was placed in a compressive dressing. Active isometric quadriceps and continuous passive movements were begun on the second postoperative day, and walking with full weight bearing was permitted as tolerated under supervision of a physiotherapist. Total operating time was recorded. Hemoglobin and hematocrit was recorded pre-operatively and at first and third day post-operatively. Drains were removed when the drainage was recorded less than 100 ml during the 12-hour period. Generally, a patient received one or more blood units if the hemoglobin level was less than 8 gram per deciliter. A linear analog scale assessed post-operatively pain at 6, 24, and 48 hours post-operatively. Time to achieve straight leg raising and range of knee movement achieved at 5 days, 10 days, and 3 months were documented by a physiotherapist. Results: a total of 60 patients were enrolled in the study after applying inclusion and exclusion criteria. that had undergone total knee replacement, 30 in each group. On analysis of demographic data, there were no significant differences between the groups with respect to age, gender, and height and weight. Upon comparison of mean blood loss in suction drain between the two groups, statistical significance was noted. Patient in tourniquet group had less blood loss in suction drain, but no comparison of overall blood loss and no significant difference were found in these groups. Pre and post operative hemoglobin levels were comparable among the groups. A slightly higher hemoglobin was evident pre-operatively in non-tourniquet group. However, this was not deemed significant statistically. Transfusion requirements were also similar among the groups, and no tendency was suggested towards the increased rate of transfusion in non-tourniquet groups. Finally, the analysis of change in hemoglobin levels after surgery revealed that use of tourniquet had no significant effect. Uh, Here we can see that only the mean measured blood loss in the suction drain was significant in the tourniquet group. In discussion, it is important to reduce the blood loss during total knee arthroplasty in elderly patients with limited cardiovascular function. Tourniquet use is the most common method to limit the blood loss. We did not encounter any technical difficulty in operating without the tourniquet in our study. Our results indicated that more blood loss occur in suction drain when a tourniquet is not used in primary TKR, but overall blood loss is the same whether tourniquet is used or not. This in contrast to findings of some authors who find increased blood loss without the tourniquet. Furthermore, there were no difference in the transfusion rates between the two groups. The main reason for using tourniquet is to achieve better cementation. Because there is less blood in the operating field, bone cement can adhere better to the bone and to the implant without blood seeping between the bone and cement. In theory, this should result in longer implant survival when performed with the tourniquet. However, since our study is short term, we were unable to comment on this aspect. The recovery of knee function was better in early post-operative periods in the non-tourniquet groups. This is one of the main advantage and in early post-operative periods. To conclude, it was concluded that the total knee replacement can be safely done without the tourniquet with respect to hematological parameters and has better knee range of motion.
Any questions from the audiences?
You have exclusion criteria of bilateral knee arthroplasty. Why? I just wanted to know for out of curiosity.
Because the duration of study was short.
How does it matter? You could have done it. Anyway, the second question, world over, everybody is using second generation cephalosporin as a prophylaxis in antibiotics. Why did you choose ceftriaxone? That is the third generation. Because world over, whatever, either cefazolin or cefuroxime people are using, you use ceftriaxone. Any reason for it?
No specific reason to maybe it was to control the infection, post-operative infections.
And one more thing, there was no mention of change in the infection rate between the two groups, I think. Was there any change in the infection rate?
We were not, our study was not aimed at infections post-operatively.
I have two questions. One, you said intra blood loss was more in non-tourniquet group, but overall blood loss was same. So how is that possible?
Uh, I don't know that. That's why we were doing this study. So in this study, we had found that
You have
overall blood loss was
overall is same.
same.
So what do you
But
mean? What do you mean by overall?
Drain and post-operative and intra-op included.
Secondly, the idea for knee replacement is for long-term survival to give patient maximum benefit for long-term, and you have not taken that into consideration. Wherever most of the literature is saying that a bloodless field will have more cement integration, and you have just not taken that into consideration. You are only focused on short-term, immediate post-op recovery and muscle function. So is that not a fallacy of your study? Because you are ignoring the thing. Because most people who are not using tunicate are not using it during dissection or bone cut. But before cementation, they inflate the tunicate 10 minutes before that so that they get a bloodless field. So I'm not against the idea of not using tunicate, but not using it during cementation is maybe deterrent to the long-term outcome.
Uh, Dr. Sparsh, first of all, I want to know why you have named your study a comparison of hematological outcomes with or without tourniquet. What is the meaning of hematological outcome? I don't think that you have included in your study the detailed hematological parameters. Only hemoglobin was assessed. Rather, you are talking about the mechanical effect for the oozing of the blood. Hematological comparison means where is the BTCT post-operatively, pre-operatively, where are the PT, PTT, all because tourniquet, the physiology of tourniquet is whenever you are applying the tourniquet, just muscles beneath the tourniquet release the uh, free radicals post surgically, which alters the hematological parameters. But in your case, you have not those included. And neither you have said, because physiology also changes post release of tourniquet, whether you are using 6 inches or 3 inches or which size and for how much duration you are using. So consider it. Okay.
Any speaker who has not uploaded his presentation may do so.
Well, now I invite Dr. Sugumar Natarajan.
Hello. Good morning.
Dr. Sukumar?
Yes, sir.
Okay.
Good morning. I am Dr. Sukumar, final year postgraduate from Savitha Medical College, Chennai. My topic is on outcome of autologous intra-articular platelet-rich plasma injection for early knee osteoarthritis. So, knee osteoarthritis is a very common degenerative articular disease characterized by destruction of articular cartilage with structural changes in the subchondral bone and synovium. And it's one of the most common causes of disability in elderly population, causing pain, decrease in range of movements, and by totally reducing the quality of their life. And recently, its prevalence is on rise because of increase in number of the geriatric population and other predisposing factors such as obesity. So the factors which aggravate and associated factors are that age of the patient, the body mass index, and the strain applied on the knee by constant weight bearing, kneeling and squatting. The aim of this treatment in this condition are to relieve pain, improve the range of movement, restore function, and thus totally improving the quality of their life. The various non-operative treatment is reserved for the older cases in much later stages, and other non-operative treatment methods include analgesics, oral contraprotectives, physiotherapy, exercises, and intra-articular injections. For a long time, there has been a need a form of treatment for early osteoarthritis in younger patients, which would be safe, cost-effective, without adverse effects, which would give good results in form of functional outcome. In past few years, the platelet-rich plasma for knee osteoarthritis has increased due to its promising results, owing to its autologous growth factor and secretory proteins, which enhance the cellular level healing process and remodeling. This study was also aimed to assess the outcome. Materials and methods. It was a prospective interventional study done in Savitha Medical College and Hospital for a total of 1.5 years between November 2018 to May 2020. And all the patients with clinical and radiological diagnosis of early knee osteoarthritis were included, and the total sample size was 80. Inclusion criteria. The patients who have chronic pain or swelling even after 6 months with no response to analgesic or NSAIDs, and radiologically Kelgren Lawrence grade 1 and 2 were included, and the patients giving consent and follow up for participation are included. Exclusion criteria. Rheumatoid arthritis, severe cardiovascular diseases, hematological diseases, infection, immunocompromised patients were excluded, and major axis deviation of valgus varus more than 5 degrees and grade 3 and 4 of Kelgren Lawrence were excluded. Procedure. Uh, After obtaining the whole blood of about 30 ml in the EDTA vacutainer, they were first sent for centrifugation. It's at 1800 rpm for 15 minutes, and the resultant supernatant above the ACD gel is again emptied into a, plasma collection tube, and it's again centrifuged for with higher RPM of 3500 RPM for 10 minutes. And again, the supernatant with platelet poor plasma is eliminated, and the platelet rich plasma, that's the bottom precipitate, is obtained. By 30 ml, we can obtain up to 3 to 5 ml of PRP. And on doing the platelet count, as we can see, in whole blood, it was 2 lakhs. And after PRP, it has increased by 7 to 8 times, that is 20 lakhs. So after obtaining this PRP, it's given by intraarticularly by 22 gauge needle through supralateral approach. And at the end of procedure, the patient's knee is put into cycling flexion extension for a few times to allow the PRP to get distributed. And after injection, the patient would be sent home for 24 hours with instructions to limit the use of leg for at least 48 hours. And only cold therapy and ice is applied for affected area of pain. And during this period, the use of non-steroidal medication is strictly avoided. And a patient can return to their mild daily activities. Sports activities can be performed as tolerated. For follow-up, we used WMAC and VAS scores. These were used for assessment at the before the procedure and at the end of first, third, and 6 months after injection. And all complications were also recorded. This is a WMAC score. Western Ontario McMaster's University's Arthritis Index, including criteria of pain, stiffness, physiological function, total points of 96 points from lesser to increased difficulties. And this, we all know, visual analog scale 0 to 10. And observation, there was 72% of males and 27% of females. And most of the patients, 36.3% of the patients had comorbid conditions such as diabetes and hypertension, and 33.8 were on previous treatment for other diseases. Age, height, the mean age of the patient was 53.8 years and mean height was 1.6 meter, and the mean weight was 66 kg and mean body mass index was 25.48. WMAC score, before this procedure it was 74. It gradually reduced. At first month follow-up it was 58.2. At third month it was 43. At 6th month it was 28.9, which was statistically significant with p-value less than 0.0001. And VAS score, before procedure it was 7.7. At first month it was 6.2. Third month it was 4.7. At 6th month it was 3. So discussion. In patients with grade 1 and grade 2 osteoarthritis, conservative management is mostly provided with analgesics, physiotherapy, counterproductives, and intraarticular injections. All of them have been used with varying degrees of success. At present, the PRP is gaining popularity due to its autologous properties, mainly two important properties. That is, it reduces the inflammation at the site of injection, and also it helps in repair and remodeling as it possesses substances such as transforming growth factor beta, platelet derived growth factors, insulin like growth factors, and even bone morphogenic proteins. And the rationale was also that as I said, it improves the tissue regeneration. It gets activated after intraarticular injection by the endogenous thrombin and intraarticular collagen. And since it's also autologous, there is no risk of allergic reactions or disease transmission, and there is no side effects. And we observe no complications other than immediate post-procedure pain. So we compared our study with that of other authors and noted that the most of the studies had good functional results following the PRP, and our study has also comparable results with that of the other studies as shown here. Our limitations, we lack the placebo or a control group, and it's a relatively short-term follow-up for just 6 months, and a longer follow-up would be required. Conclusion: by this study, we conclude that the PRP is a simple, cost-effective, safe, and efficient procedure with easily reproducible results and give good functional outcome in terms of pain relief, improved range of movements, mobility, significantly improving the quality of life with early osteoarthritis happening.
Okay. Thank you, Dr. Sukumar. Questions from audience? Open. Any question? Okay, Dr. Sukumar,
Yes.
you said that no non-steroidal anti-inflammatory any other analgesics were given post-injective
Yes, sir.
injectable therapy. It was not given.
It was actually not given, sir.
Okay, and what other precautions you told to your patients? You showed in your slide that biking and it was allowed, but
Yes.
usually we do advise to the osteoarthritis patients to avoid the squatting, cross-laxating, so the intraarticular pressure can be reduced to save the cartilage.
It is as
In
much
your
as-
study you advise such precautions or not?
It's as much as tolerated, sir. It's
Pardon?
as much as tolerated.
Okay, according to pain tolerance.
Yes, according
And
to pain
frequency of your injections?
Just one injection, sir.
Just one. Okay, thank you.
Thank you. Sir.
Thanks for a nice presentation.
Thank you.
Now I invite Dr. Vivek Singh Thakar, a prospective comparative study between osteosynthesis and cemented hemiarthroplasty as regards to the functional outcome in neck femur. Be careful regarding the time limit.
Okay. A very good morning to all of you. I'm Dr. Vivek Singh Thakar from Gwalior, presenting a paper on prospective comparative study between osteosynthesis and cemented hemiarthroplasty as regards to the functional outcome and survival and fracture neck of femur in elderly population under the guidance of Dr. R.K.S. Thakar sir. The hip fractures, intracapsular hip fractures are more common in elderly population, and the neck femur fracture being the commonest one. The treatment options include either you replace the head or you fix it. The proponents of replacement argue that the replacement eliminates the risk of uh, major complications like avascular necrosis, non-union, which can result into higher rates of revision operation. The aim of my study is to evaluate the functional outcome and quality of life of patient aged above 50 years with femoral neck fractures after being treated with both these methods. The patient who have intracapsular neck femur fracture are aged above 50 years, have independent ambulation before the injury, or are not having any pre-existing hip pathologies are included in the study. The patient who had old neck of femur fracture with absorbed neck and viability of head is jeopardized are operated with definitely with hemiarthroplasty. 100 patients allocated into two groups, 46 into 1, with treated with internal fixation, and rest of them were treated with hemiarthroplasty. The internal fixation method included all the methods of internal fixation like VDSF, conventional CC screw figuration, and DHS. You can see the intraoperative images of approaches of hemiarthroplasty with the postoperative radiograph. See the intraoperative C-arm images of the internal fixation. The usual follow-up protocol was similar to both the methods, but in case of weight bearing, it was started as early as third postoperative day. In case of hemiarthroplasty, but in internal fixation, the weight bearing was encouraged as soon as it was possible, depending upon the pain of patient, and it was initially encouraged with support, and later on it was removed. The results, we actually compared the result in terms of functional outcome, and it was scored with the common Harris-IP scoring system. In hemiarthroplasty, almost 88% patient had fair to excellent Harris-IP score, while only 7% had poor Harris-IP score at the last follow-up of 6 months, while in internal fixation, 34 patient at last follow-up recorded the poor Harris-IP score. Here is the evaluation of the table comparing the results of Harris-IP score in both the methods. You can see only the 4 patient among the 54 patient of hemiarthroplasty at initial follow-up and the last follow-up at the poor Harris-IP score. But in case of internal fixation, you can see almost 14% out of 44 had poor one. And you can see the excellent score only 2 patients of internal fixation group could achieve after the last follow-up. In terms of mortality, blood loss, duration of surgery, reoperation, if we compare these methods, mortality and duration of surgery was almost equal. Blood loss had a significant difference of around mean of around 120 ml, while the reoperation rate, it was recorded 5.5% in case of hemiarthroplasty, but it was almost 20% in case of internal fixation. The cases showing the preoperative radiograph and the follow-up images of hemiarthroplasty, the functional range of motion in the clinical images, patient fixed with the internal fixation in conventional inverted triangle fashion. Major healing related complications like non-union, fixation failure, osteonecrosis occurred in internal fixation group. No significant difference in my study I found in deep infection rates of both these methods. The overall complication rate was around 47% in internal fixation group, while it was as low as 11% in hemiarthroplasty group. The table depicts the complication enlisted like deep infection. It was only 4.4% internal fixation, while you can see the non-union rates, almost 33% patient had non-union, 8% patient developed implant failure. Even if the patient has united with this fixation, the rate of AVN is still higher, as high as 9% in the united cases. See the complication in hemiarthroplasty, you can match the infection rates were almost equal. There is a prosthetic hip dislocation of around 4% in hemiarthroplasty group. And you can see the revision operation rates of 5.5%, or in internal fixation group, it was around 20%. Cases, neck femur fracture operated with BDSF technique. You can see in follow-up images, a perfect union is over there, but in later follow-up, you can see the AVN, development of AVN in femoral head. Other fracture fixed with the BDSF technique, you can see the lateral migration of screw and fixation failure. Another radiograph fixed with conventional CC screws, and you can see the non-union and fixation failure and lateral migration of screw in the follow-up radiograph. Another patient, you can see development of internal migration of screw into the joint of a patient fixed with BDSF technique, and it was then revised with hemiarthroplasty. Other radiographs showing the non-union. This patient also developed the avascular necrosis of femoral head following the fixation with internal fixation. This was the patient operated with hemiarthroplasty, which developed prosthetic hip dislocation, which was openly reduced later on. As you all know, it's a matter of debate to discuss the treatment of both these options, especially in elderly population of 50 year and above age of life. Fixation method actually are debatable on the basis of fracture pattern, time of patient's presentation, intraoperative fracture reduction, preoperative comorbidity, and other patient-related factors. Nevertheless, numerous randomized studies have provided evidence of better functional outcome after arthroplasty when compared to internal fixation in terms of overall function scores, abductor muscle functions, and independent ambulation without walking aids. Although perioperative blood loss and length of hospitalization were statistically lower in internal fixation group in comparison with hemiarthroplasty, the reference studies are there. If I conclude the study, I will say that the present study showed that hip arthroplasty compared to internal fixation in treatment of femoral neck fracture in elderly population significantly reduces the risk of reoperation following the complication, but at cost of higher superficial infection and blood loss. Furthermore, post-operative function evaluated by Harris-IP score was significantly higher in hemiarthroplasty group as compared to internal fixation group. Thank you very much, sir.
Thank you, Dr. Vivek. Any questions from the audience?
Was there any informed consent taken while taking a patient for surgery? What I mean, did you explain the benefits and advantages? My question is that was there any informed consent taken before the surgery?
Yes, sir. Consent was the first thing that we did in the
Informed
patient.
consent
Yeah, it
mentioning
was
the
informed and written.
benefits,
Yes, sir.
benefits and merits and demerits of individual surgery.
We explained the merits of both the methods. A choice was given to the patient and informed consent with written consent taken with all the patient.
The reason is
Include-
that 50 is the age usually patients are active. Most of the patient we expect at least till the age of 65 they remain active. We must tell them that what are the losses they are going to have if they are subjected to hemiarthroplasty. Only disadvantage with the internal fixation is that you might need a revision of surgery. And as you said, the failure was not as high in internal fixation.
Yes, sir.
So one must try internal fixation always, rather than, of course, it has its own problem. As you said, yes, it is true. In hemiarthroplasty, you can mobilize immediately, but let patient choose what they want always.
The patient were given the options, and as you said, sir, both the risk and benefits were explained.
So you have
In
not
case of-
mentioned here. You should have mentioned that.
Yeah, okay, pardon me, sir.
Secondly, if you say that there is radiological appearance of avian in internal fixation group, so you should know that even after it appears radiologically, to be clinically such significant they need replacement, it takes another few years. So just a radiological evidence that doesn't mean that it has failed. Internal fixation will still give after avian another 4 5 years to patient.
Sir, as the radiological evidence appeared, the patient were informed about the complication, and later on they were prepared for the surgery. Yes, sir. Definitely it will last.
I want to ask two questions, Dr. Thakkar. First, you did the both surgery simultaneously in your study design. Both groups are having fresh fractures because you showed in your slides the patient already had the screw fixation, and you included in your study.
Uh, the patient, when it was included, that patient, sir, it was primarily been fixed with the internal fixation. Later on, it was revived with hemiarthroplasty. And I'm comparing the result of primary fixation of both these methods.
In bo-
And in terms of
what I am
patient,
understanding, what you are saying, patient with the fresh fracture net femur, age group 50 onwards came to
Yes.
you, and in one group you just directly went for the hemiarthroplasty, in other one you internally fixed.
one more thing, sir. If the patient presentation is bit longer, it is not acutely presenting, then we opt for hemiarthroplasty in those patients whose head has, whose neck has absorbed and the viability of head is compromised. We chose to do hemiarthroplasty in those patients. We did not go for internal fixation.
Okay. The second question is, as the Dr. Saab raised a very valid question, your study duration is less. Okay. In a physiologically as well as the chronologically active person of age of 50 years, less than 60, and if you are going for the hemiarthroplasty, deliberately we are also disposing the patient for the revision surgery for total hip arthroplasty. After a few years, as you know, the implant longevity, we understand that.
Yes, sir. Definitely, implant longevity of hemiarthroplasty is much lesser than the total hip. But sir, here is the risk of reoperation is the main consideration.
It is
So
short
we are-
term. Risk of reoperation is short term. Preservation of your own head in patients, 70% of patients' head can be salvageable. And if we are just giving them the option and we are operating on that, revision surgery is 30% in these cases. In a hemiarthroplasty at the age of 50 year, certainly after the 20-year case will be revised.
Considering these facts, sir, we recorded almost 47% rate of complication in internal fixation. This is why even salvageable head has been gone into uh, in terms of we can say in failures and revision operations.
Okay. Thank you, Dr. Vivek.
Thank you very much, sir.
One more thing, you used Indian implant or striker or Zimmer stem?
Sir, all the implants were Indian.
Indian, cemented or uncemented?
It was cemented hemi.
All
It is
Yes.
criteria of study. Okay. Thank you, Dr.
Thank you very
Vivek.
much, sir.
Now I invite Dr. Milind Chandra Chaudhary, and other participants who are here not uploaded their study material. They can upload their study material. How does medial compartment osteoarthritis of knee respond to proximal fibular osteotomy at 1 year?
Good morning, everyone. Today, my topic for presentation is how does medial compartment osteoarthritis of knee respond to proximal fibular osteotomy at 1 year, a prospective analysis of 26 knees. Osteoarthritis is a very common joint disease with an incidence of 30% of population in 60 older than 60 years. Medial compartment osteoarthritis is very common, almost the commonest non-communicable disease in India, and around 50% of Indian population have varus knee. Knee varus deformity is characterized by mechanical femorotibial axis of less than 180 degree on full leg standing anterior posterior radiographs, and narrow medial joint space are common in patients with knee osteoarthritis. High tibial osteotomy, unicompartmental knee arthroplasty, and total knee arthroplasty are commonly used methods for treating medial compartment osteoarthritis. Materials and method. Inclusion criteria: medial compartment osteoarthritis with varus knee. Callaghan and Lawrence classification, we included grade 2 and 3. Good lateral joint space on weight bearing X-ray films, age more than 20 years. Exclusion criteria included severe osteoarthritis, inflammatory arthritis, genu-valgus deformity, acute major trauma, 0, 1, and 4 osteoarthritis, knee in Callaghan and Lawrence classification, lateral joint space less than medial joint space, and lateral compartment osteoarthritis. The surgical technique was osteotomy site was determined to be 7 to 9 centimeter from the head of the fibula. The rationale behind choosing this level of osteotomy is to avoid injuring the common peroneal nerve. 1.5 to 2 centimeter of fibula was then resected with the help of an oscillating saw. All patients were encouraged to stand and walk on the same evening. Follow-up period was 1, 3, 6, and 12 months. Knee pain was assessed using a visual analog scale, and knee ambulation activities were evaluated using the American Knee Severity Score, preoperatively and postoperatively. These are the results. Pre-op, the mean score in American Knee Society was 33.5 with a minimum of 24 and maximum 45. And post-operatively, the same was evaluated, which gave the result of 83.57 with a minimum of 78 and maximum of 90. These are the pre-op and post-op X-rays at 3 and 12 months of follow-up. Now discussion. However, high tibial osteotomy is associated with a longer recovery period and a prolonged period of non-weight bearing walking until the union of osteotomy site, and there can be issues with recurrence of the deformity. Unicompartmental arthroplasty is associated with problems like polyvia, progression of the arthritis, or loosening of components. Total knee arthroplasty is expensive and complex, and some patients need a second knee revision after the first surgery. In this scenario, there is a need for a procedure that is simple to perform, easily reproducible, gives good functional result, and is associated with a shorter recovery period, thereby improving the quality of life of affected patients. The rationale behind proximal fibular osteotomy is the concept of non-uniform settlement. The word settlement has been borrowed from the field of architect, where the phenomena of gradual sinking after the construction of a structure is seen. The support of the fibula by the lateral tibial plateau does not allow the lateral side to settle, creating a varus deformity. This has been called non-uniform settlement. The rationale behind PFO is that when this support of the fibula is removed, the lateral side settles down, loading the proximal tibia evenly and leading to the correction of the deformity in a varus knee, thereby relieving symptoms and reducing the deformity. Another theory, too many cortices theory. Figure A shows a normal knee, figure B shows a arthritic knee, and figure C shows after a post-op knee after the proximal fibular osteotomy. In figure 1, there is equal forces acting on the medial and lateral side of the knee. In arthritic knee, there is more of the lateral forces acting, less forces are acting on the medial side because of the trabecular resorption of the bone due to osteoporosis. On the lateral side, the fibula has is a cortical bone, and it provides 3 cortices on the lateral side, including one cortex of the tibia, and the fibular cortex, the cortical bone don't get resolved during the osteoporosis. In after proximal fibular osteotomy, the lateral strut forces by the fibula is removed, and there is a balance between the medial and lateral forces. The slippage phenomena, due to non-uniform settlement, the femur slides to the medial side. This phenomena is called coronal tibiofemoral subluxation or the slippage phenomena, which further increases high knee adduction moment, thereby further enhancing the non-uniform settlement, leading to progression of varus deformity. Uh, Dynamic fibular distalization theory. The greater the distal displacement of the fibular head, the better was the correction of the varus deformity, and more significant the improvement of the symptoms. PFO acts by weakening the support laterally, correct the varus deformity, and shift the stress from medial to lateral compartment, resulting in an alleviation of pain and gives a good functional outcome. PFO is a promising alternative procedure in the management of medial compartment osteoarthritis of the knee, being a simple and cost-effective alternative to a traditional total knee arthroplasty and unicondylar knee replacements. Thank you.
Okay. Thank you, Dr. Milin. Any questions from the audiences? I want to ask two questions. As we know, in the early osteoarthritis, whenever the patient gets relief in the medial compartment pain because of the decompression of the subchondral bone, in this your study, we have not followed that principle. You said that it is a different principle of settlement.
Yes, so uniform settlement.
This settlement can lead to over settlement also. Number one. Number two, your study duration. Your study is very specific. I'm impressed with this thing. You are studying a result at 1 year.
Yes, sir.
But this 1 year is too short
Yes, sir.
to
That's the
assess
limitation
the
of study.
success of any study.
It should be long, yes, sir. It's a limitation
It
of the
because osteoarthritis is a progressive disorder. Just at the 1 year, we can't predict that it will
Yes,
be.
sir. It's a
benef-
limitation of the study.
Yeah. Any more questions? Thank you. Thank you, Dr. Mili. Now I invite Dr. Pritender Paul Singh. Comparison of clinical and functional outcome of ultrasound guided versus landmark guided corticosteroid injections in adult with frozen shoulder.
Good morning, everyone. Myself, Dr. Pritender. Frozen shoulder is one of the many painful shoulder conditions which presents with the progressive loss in range of motion, both active and the passive range of motion of the shoulder joint. It is prevalent in about 2% of the general population with the female predilection. Female to male ratio is 4:1. Usually, it is a self-limiting disease, can be classified into primary and secondary stiff shoulder. Diagnosis is usually made based on the patient's history and the physical examinations. Radiographs are particularly normal, but they should be done to rule out any fractures, any glenohumeral arthritis, or any tumors or any other conditions. Corticosteroid injections are an established conservative method for the treatment of the frozen shoulder, as they give short-term benefits in terms of shoulder mobility and pain reduction, and they basically alter the disease course. And for the late disease or the recurrence after conservative therapy, surgical management in the form of mobilization under anesthesia or arthroscopic capsular release has been described. So our research question was like basically whether ultrasound is better, ultrasound guided intra-articular steroid injections are better, or the landmark guided. Previous literature, Redo et al., Lee et al., and Kunku et al. Have reported that the ultrasound guided intra-articular corticosteroid injections are better in terms of relieving pain and range of motion of the shoulder. But Rasirata et al. And Moore et al. Have reported no significant difference. So our aim was to compare the clinical and functional outcome of ultrasound guided versus landmark guided intra-articular steroid injections in adults with frozen shoulder in early stages, that is stage 1 and 2. An objective was to assess the clinical outcome of ultrasound guided versus landmark guided intra-articular corticosteroid injections in adults with frozen shoulder using visual analog score to assess improvement in pain and a constant Murley score to analyze improvement in functional outcome. Next. This was a randomized control done in our medical college tertiary care center in MGMCRI Puducherry. The following data was collected like patient particulars, name, age, sex, address, and occupation, and the history, duration of symptoms, whether it was unilateral or bilateral involvement, any comorbid illness such as diabetes and mellitus, and the examination of the affected shoulder was done. So the inclusion criteria was patients with primary frozen shoulder stage 1 and 2, and exclusion was previous history of any intra-articular steroid injection in the ipsilateral shoulder, secondary frozen shoulder, septic arthritis, skin abrasions, and superficial infections. The following investigations were the complete blood count, blood sugar profile, fasting, random, postprandial, and HbA1c was done. This is the technique of the landmark guided injection. The landmark guided, it was the 2 centimeter below and medial to the posterior lateral corner of the acromion. This was marked as the injection site. And after the needle head was confirmed, the intraarticular corticosteroid injection, which drug mixture, which consisted of 1 ml of 40 milligram per ml of triamcinolone acetonide and 2 ml of 2% lignocaine, was injected. And this is the drug mixture we are injecting under ultrasound guidance. And after that, the shoulder was mobilized immediately and sequentially through a range of forward flexion, extension, abduction, internal rotation, and external rotation. Patient was observed for any adverse reactions to the injection. This maneuver is the Codman's maneuver. And for the post-procedure, all the patients were given analgesia for 5 days, and they were subjected to strict physiotherapy protocol in both ultrasound as well as the landmark guided group. And patients were counseled regarding steroid flare and to take tablet diclofenac if they have increased pain and inflammation. And they were taught about the pendulum exercises, wall climbing, stretch, and gentle range of motion exercises. And patients were followed up 2 weeks, 1 month, 3 months, and 6 months post-procedure. And at every assessment, the functional outcome was evaluated using constant Murley score, and the pain outcome was evaluated using visual analog score, and the range of motions was also evaluated, and if any complication, they were also noted. So statistics, using SPSS software 26, it was analyzed. Confidence intervals were set at 95%, and a statistically significant value of p less than 0.05 was kept. And descriptive statistics was used to calculate numbers, percentages, mean, and standard deviations. And comparison was test of significance was done using Fisher's exact test for demographics, sex, and diabetes. Same. So results: a total of 40 patients which satisfied the inclusion criteria were incorporated into the study with frozen shoulder stage 1 and 2. No patients were lost to follow-up, and the average age of the patient was 57.83 plus minus 9.1, as frozen shoulder is common in the 4th and the 4 to 6 decades. And mean age in the landmark guide was 59 plus minus 7.2, ultrasound was 56 plus minus 10.6, and 70% of patients are in the 4 to 6 decade group. So this is the VAS. The pre-treatment at the landmark guided, the mean VAS at presentation was 7.8, and in the ultrasound guided, the mean VAS was 8.0, and this had a statistically non-significant value of 0.4. At 2 weeks, there was improvement in both the visual analog score in the patients in landmark guided as well as the ultrasound guided group, but there was more improvement in more reduction in pain in the ultrasound guided group as compared to the landmark guided group, which can be shown with the as described by the statistically significant value of p.001. Similarly, at 4 weeks, the mean VAS from the mean VAS came in the landmark was 2.1 and the ultrasound was 1.2, and this comparison was also statistically significant. But at 3 months and 6 months, although the pain was reducing, but there was no statistically significant difference between the two groups. Similarly, in the functional scoring constant Murley, the mean CM score at presentation for the landmark was 66.2 and ultrasound was 63.3. And at 2 weeks and 4 weeks, again, there was significant improvement in the function in both the groups. But comparatively, the ultrasound guided group has a better improvement as described by the statistics value of 0.05. But at 3 months and 6 months, there was no statistically significant difference. So this was along with the diabetic, we also compared the diabetic and the idiopathic frozen shoulder for VAS and the constant Murley scoring. There was no difference in improvement in terms of pain and function if we compared with the diabetic and the frozen shoulder, whether given by in both the diabetic and the idiopathic frozen shoulder. And similarly, this was a CM score. There was also not significant, statistically significant difference. So discussion, we took the patients in the early stage of the frozen shoulder, that is stage 1 and 2. Both the groups had reported significant improvements in pain and functional outcome and range of motions. But in the initial earlier follow-up in the 2nd and the 4th week, ultrasound guided intraarticular corticosteroid injections had better results compared to the landmark guided. And that came maybe because under ultrasound guided, we are injecting the steroid directly into the putative site of the pathology. However, at 3 months and 6 months, there was not statistically significant difference. In the long term, both groups had similar results in terms of pain and functional outcome. So this was the comparative study done between our study and the previous literature as described. So in our study and study done by Naredo et al., Lee et al., and Okonkwo et al., they have found a significant difference in terms of pain decrease in difference between the ultrasound guided and the landmark guided, but Resirata et al. And Moore et al. Have reported no significant difference. Similarly, these are the comparison of the various shoulder function scores done between which we found in our study and other literatures. Here also, Resirata et al. Have reported no statistically significant difference. So in comparison to diabetic versus idiopathic, at presentation, the mean constant Murley score was slightly less in diabetic patients, and mean VAS was also higher in case of diabetic patients. But at the 6 months follow-up, there was no the mean constant Murley score, although it was higher in the idiopathic frozen shoulder, but this was not statistically significant compared to the diabetic frozen shoulder. So the limitations of this study is that there's a small sample size, only 40 patients are there, and we can recommend future studies with a larger sample size to further conclude. And the blinding of the participants was not done. Only patients are followed only up till 6 months, and for a single center study. Plus, the diabetic evaluation of the patient was not done at the subsequent follow-ups. So conclusion, single dose of corticosteroid injection benefits patients with frozen shoulder, irrespective whether it was given either by ultrasound guided or landmark guided. And overall improvement was seen in pain and functional outcome in both groups, with no complications seen in both the groups. And ultrasound guided technique offers faster reduction of pain and improvement in range of motion and shoulder functions during early stage of treatment compared with the blind technique. So it is a useful treatment and can be recommended as a preferred technique for giving intra-articular steroid injections in the early stages of frozen shoulder. Thank you.
Okay. Thank you, Dr. Pritinder. Any questions?
Have you ever done MRI in any of your patients?
No, sir. We didn't do any.
The
MRI.
reason is that only contraindication to this steroid treatment is partial tear in the rotator cuff. It might lead into complete tear. That's it. So we have to know why this, especially in history of injury, one can go for MRI before giving an injection.
So
of
if
course,
there was any certain history of any injury to the ipsilateral shoulder, so those patients were already excluded out. And in the subsequent, we took X-ray radiographs of all the affected shoulders. So and the proper examination of the shoulder, and if any rotator cuff tear or any weakness in the supraspinatus tear and all, those patients were excluded from our study, sir.
because I would compare it with steroid injection, retrocalcaneal bursitis. It sometimes leads to the tear in the TC.
Yes, sir.
Similarly, here it may convert a partial tear into a complete tear. That's the only problem. Otherwise, giving a steroid is not an issue. It's a good thing. Thank you.
Thank you, sir.
One question from me. Dr. Pritinder, indications for your comparative study was primary frozen shoulder. You mentioned in your study.
Yes, sir. Primary frozen.
So what do you understand by primary?
The primary frozen shoulder.
Is there was no underlying cause like the diabetes, injury, and anything?
No, diabetes and hypothyroidism, they are one of the causes for development of primary frozen shoulder only, sir. So diabetes is one of the most common cause for, like, in primary frozen shoulder is found very commonly in diabetic patients. Like other causes, for example, the post-traumatic or the brachial plexus injuries or any CVA, those causes are for the secondary frozen shoulder, secondary stiff shoulder. Those patients were ruled out, excluded out from our studies. Patients with any septic arthritis of the shoulder.
Okay, thank you. Now I invite
One question.
Dr. Piyush Sureka.
Can you properly examine rotator cuff in a patient with frozen shoulder clinically?
Sir, actually, problem is that in frozen shoulder, there only will pain and active and the passive range of motion. Both will be restricted similarly.
So you cannot examine rotator cuff in.
Yeah.
The
So passive,
that thing is.
but passive movement will be full in the case of the rotator cuff tear, sir. Then the
No. In your study is in frozen shoulder, so you
yes,
cannot examine rotator cuff. Secondly, regarding steroid, I think it is intracapsular, so it doesn't matter whether rotator cuff
we
is
know that.
torn or
Yes,
not.
sir.
Okay, thank you. Dr. Piyush Sureka. Functional outcomes of multi-ligament knee reconstruction.
Good morning to one and all, to all the delegates and to the respected faculty. So my study is on a functional outcome of multi-ligament knee injuries after reconstruction, a prospective study. So the aim of the study was to assess the functional outcomes of the knee in a patients of multi-ligament knee injury after the surgical reconstruction using the standard scoring systems for the knee. So introduction, the multi-ligament knee injuries are basically two or more knee ligaments injured, mainly the ACL, PCL, MCL, LCL, and the posterior medial lateral corners. And the role of these ligaments are not only to maintain the knee in a rigid position while standing, but it also orchestrates the biomechanics of the knee motion in the harmony. It is relatively uncommon, but it is intimately related to the knee dislocations, where the incidence is less than 10 in 10,000 of trauma cases. And unlike single knee ligament injuries, the multi-ligament knee injuries are difficult to treat, and there are very few clinical studies on it. So materials and methods, the study design was prospective observational study conducted from February 2019 to March 2020 with a sample size of 8 patients which were evaluated first for the knee instability. The clinical examination was done with a high suspicion. Stress X-rays were done, MRI and the MRI knee was done. The diagnosis was taken gold standard by MRI, where the disruptions of the ligaments were seen in sagittal plane. Mostly we could see the ACL and the PCL injuries, whereas in the coronal view we could see the posteromedial and lateral corner injuries. And then followed by that, stress X-ray imagings were done in valgus, varus stress, and healing stress. And then the instabilities were measured according to the available index grades. And then clinical examination specific ligament tests were done under anesthesia where they were taken for the surgery as well. And the reconstruction technique was done as described by the Laprade et al., where using the semitendinosus gracilis graft or the peroneus graft arthroscopically. And the surgical options involved the reconstruction of the ligaments using interference screws and tight ropes with the help of semitendinosus gracilis and or peroneus graft of the same or opposite legs. And the physiotherapy protocol, it is the one of the more core principles of the multi-ligament knee injury, without which our surgeries is likely to give a poor outcomes, and it shines in the progress of the early mobilization and rehabilitation. So the protocol we followed was, for the first 2 weeks, quad strengthening, straight leg raising, and ROM till 90 degrees knee flexion on a hinged knee brace was done. From 2 to 6 weeks, the ROM was increased to more than 90 degrees knee flexion, and rest always continued as before. After 6 weeks, partial weight bearing with crutches were started, and after 10 weeks, full weight bearing was allowed. The target of our physiotherapy protocol was first to decrease the pain, then followed by slowly increasing the range of motion, and then strengthening the joint muscles. And to increase the functional outcomes, new modalities have even come, like infrared treatment, shockwave therapy, hydrotherapy, physical massage, and active exercises, achieving simple and complex tasks. So the inclusion criteria were the patients sustaining the injury for less than 12 weeks old, and all ages above 15 years old, and all the patients with diagnostic MRI confirming the multi-ligament knee injury, and genders of all genders were male, female, both were included. And the exclusion criteria was more than 12 weeks old, children, morbidly ill patients with ASA classes 4 or more, which has a constant threat to their life, patients with active knee infection, and patients undiagnosed by MRI. So results, so all the 8 patients which were included in the study were between the range of 30 to 40 years of age. So out of these 8 patients, as we can see, there are 3 patients who had a Schenck classification type 3L, which included ACL, PCL, as well as posterolateral corner. And there were 4 patients with type 2, where only ACL and PCL were involved. And there was 1 patient which had type 3 and there was 1 patient which included ACL as well as posteromedial corner. And then the functional outcome was done with the help of Lysome knee scoring system, which includes 8 factors, including the pain, swelling, knee instability, limp, support. So total there are 8 factors, which sums up to 100, the scoring. And so out of the 8 patients, 3 patients had excellent outcome with score of 95 to 100. The 2 patients had a good outcome with 84 to 94, and 3 patients had a fair outcome with score of 65 to 83. So discussion. Most of our patients were between the 3rd and the 4th decade of life. This is mainly due to the nature of injury, as all the patients of our study were due to road traffic accidents, the mechanism of injury. And then the Lysome knee scoring system of our subjects who had reconstruction surgeries were far better than those which didn't have any intervention, because these ruptured ligaments do not heal mainly due to the mechanical and the biological factors rendering them widely apart. And if these cases are not treated nicely, these lead to chronic instability and consequences just such as joint stiffness and secondary osteoarthritis. which comes from the basically from the unequal loading of the joint, and not to mention the associated meniscal tears, which even worsen the functional outcomes of such cases. And the reconstruction surgery is the main outcome is dependent on doing first taking the proper size and strength of the ligament grafts, then maintaining stability, and then immobilization, and the following proper post-op physiotherapy, facilitating pain relief and decreased swelling, which leads to better outcome. If there's no decreased pain and swelling, the patients are unlikely to follow your protocol, the post-op protocol, and which will lead to poorer outcomes. And ACL was most affected ligament found, mainly because of the mechanism of injury, mostly involving the frontal impact during the road traffic accidents, or multiple forces affecting the knee, as in the twisted knee in sport injuries. And what we found was the ones which were excellent outcomes were the ones which involved only the sagittal plane torn ligaments, like the ACL and the PCL. So basically the ACL, PCL, sagittal plane torn ligaments would have a better outcome than the oblique plane torn ligaments, like the posterior medial corner and the posterior lateral corner. And two ligaments reconstructed is better than having one reconstructed and one repaired. That was found in our study. So and then young patients would have a better prognosis than the older one, with because of the fact that younger people are more eager to come back to their daily lifestyle and to join the sport activities, and also of the fear of the older ones from re-injuries on top of the existing comorbidities like osteoarthritis. So basically the physiotherapy has a major role in the treatment, and gender effect on the functional outcome of knee injury was not yet clear, and BMI and nutritional status was found not to affect the outcome of the ligament injuries. So before we conclude, we always need to know about the limitations of our study. So this was basically a small case series of 8 patients. We need to have a better and a larger sample size with a larger follow-up. Our follow-up was after 6 months, so we need to have a larger follow-up. And there are also still there are controversies regarding the order of fixation, but we followed the Laprade et al. So very limited clinical evidence is there, and we need to go for more studies. Thank you.
Okay. Any question? Okay.
Thank you, sir.
Now I invite Dr. Tarun Nogaria. Dr. Tarun, changes in hematobiochemical, radiological, and synovial fluid parameter in patients of osteoarthritis knee with effusion.
Good morning to all of you. I am Dr. Tarun Nogria. My research topic is changes in hematobiochemical, radiological, and synovial fluid parameter in patient of osteoarthritis knee with effusion, a prospective observational study guided by Dr. Sami Gupta. Osteoarthritis is most common form of arthritis and single most important cause of disability in older adults. Osteoarthritis is defined as degenerative joint disease characterized by cartilage breakdown, formation of bony outgrowth at joint margin, subchondral bone sclerosis, alteration of joint capsule, and inflammation of synovial membrane. This schematic diagram shows a normal knee compared with the osteoarthritic knee. In normal knee, there is a no thickened joint capsule, no inflammation of synovial membrane, no destruction of the articular cartilage, and no decreased joint cavity. And there is no change in the bone. Whereas in osteoarthritis, there is a thickened joint capsule, inflammation of the synovial membrane, early degeneration of the articular cartilage, bony osteophytes present, and bony sclerosis is also present. Radiological classification and use for osteoarthritis knee is Calgren-Lawrence classification, which is divided into 5 grades. Grade 0 is no change in the radiograph. Where in grade 1, there is 1 mm osteophyte present with or without less than 25% decrease in joint space. Grade 2 is 1 to 2 mm osteophytes and 25 to 50% decrease in joint space. Grade 3 is 2 to 3 mm osteophyte and greater than 50% decrease in joint space. Grade 4 is multiple large osteophyte and definite bony and deformity. A strong indicator of synovitis is clinical symptoms of inflammation, presence of histological inflammation in osteoarthritic synovial tissue, early cartilage lesion at the border of inflamed synovium. So this diagram shows the involvement of synovium in osteoarthritic physiology. Pres- Presence of cartilage breakdown release the cartilage destruction product in the synovial fluid engulfed by the synovial cell, which amplify the synovial inflammation, and activated synovial inflammation causes activation of the B cells, CD4 cell, and T cell that causes the release of the inflammatory mediator and catabolic mediator that causes the increase in the degradation of the cartilage. This causes a positive loop, and in response to cartilage destruction, there is a release of the anti-inflammatory mediators also. A prospective observational study was conducted to determine the changes in hematobiochemical, radiological, and synovial fluid parameter in osteoarthritis knee with effusion. The study was conducted to correlate the cases osteoarthritis knee with effusion and control osteoarthritis knee without effusion with radiological, hematobiochemical, and synovial fluid parameter to find out the incidence of synovial effusion in radiological staging of the disease. A study was conducted in Department of Orthopaedic, J Hospital, Gwalior. Patient aged 30 to 85 with complete clinical record and willing to participate were included in the study, and those who are not willing to participate and clinical evidence of other joint disease other than osteophytes are excluded from the study. 100 patients were examined with complaining of knee pain. From selected patient, osteoarthritis knee with effusion and without effusion are separated. Hematobiochemical, radiological, and TNF alpha level in sinus fluid were measured and data were assessed. Then Pearson chi-square tests were applied for association and trend. TNF alpha testing was done by the ELISA method, and these shows the test after adding the streptavidin HRP solution in all well, and after adding the anti-TNF alpha solution in all the wells. So result shows that there is a in osteoarthritis knee with effusion shows TNF alpha level positive in 28 cases out of 50, shows a positive correlation of TNF alpha level in osteoarthritis knee with effusion patients. It shows there is a maximum cases in stage 2 in early osteoarthritis in osteoarthritis knee with effusion patient, showing a positive correlation of osteoarthritis in stage 2 in effusion patients. There is a no significant correlation between the total leukocyte count in blood with radiological staging of the disease in osteoarthritis. The level of ESR is raised in osteoarthritis knee in effusion patient as compared to osteoarthritis knee without effusion patient. This shows a significant correlation of ESR with osteoarthritis knee with effusion patients. There is a no significant correlation found between serum calcium and radiological staging of osteoarthritis knee patients. This table shows the correlation of the ESR with radiological staging of the disease. Mainly the ESR is raised in stage 2 of osteoarthritis with effusion patient. The CRP level are positive in osteoarthritis knee with effusion in 30 patients. So this shows a significant correlation of CRP in osteoarthritis knee with effusion patients. There is no significant correlation found in the level of hemoglobin with radiological staging of osteoarthritis. So association between TNF alpha and osteoarthritis with effusion was found significant. There is a correlation between TNF alpha and synovitis, and inflammatory marker is increased in synovitis. Association between ESR, CRP, and osteoarthritis was significant, and study concluded that osteoarthritis is also associated with inflammation. Effusion mainly occur in early stage of osteoarthritis and occur in early stages and associated with inflammation. Although statistically not significant, the portion of osteoarthritis in case of male was marginally higher than female. Association between hemoglobin and osteoarthritis was not found significant. So study evaluated the association of CRP with osteoarthritis knee with effusion patient. In a 50 patient with osteoarthritis knee with effusion found CRP positive in 30 patient, which is significant higher than osteoarthritis knee without effusion. CRP level elevated in osteoarthritis knee with effusion as compared to osteoarthritis knee without effusion patients. Study evaluated the association of ESR with osteoarthritis knee with effusion patient. In 50 patients with osteoarthritis knee with effusion, ESR is raised in 32 patients, which is significantly higher than the osteoarthritis knee without effusion patients. ESR elevated in osteoarthritis knee with effusion as compared to osteoarthritis knee without effusion patient. ESR is significantly raised in stage 2 of osteoarthritis with effusion. Con- Concluded that this study shows that there is an inflammation is also associated with osteoarthritis knee with effusion. Osteoarthritis with knee with effusion mainly occur in early stage of osteoarthritis. Blood parameters are significantly higher in osteoarthritis with effusion as compared to osteoarthritis knee without effusion patients. Targeting inflamed synovium should delay or prevent articular cartilage damage and osteophyte formation, especially in early osteoarthritis. Anti-TNF alpha and anti-inflammatory drug may be considered for treatment of osteoarthritis, and anti-TNF alpha may be considered in reducing sign and symptom of inflammatory osteoarthritis of knee.
Okay. Thank you, Dr. Tarun. Any questions from audience? So you suggested it is the stage 2 in
Yes, sir.
osteoarthritis.
Yes.
That should be the target area so we can prevent the further progression.
Yes, sir.
Yes, sir? You are asking some question?
Yes, sir. We in our study we concluded that early stage osteoarthritis mainly inflammation is present in early stage stage 2 of
No,
osteoarthritis.
usually the fundamentally we consider osteoarthritis is a degenerative process,
sir.
not inflammatory
Yes,
process.
sir.
But in your study,
Yes, sir.
you highlighted the point that in the stage 2nd,
Yes, sir.
whenever there are effusion and synovial inflammation is there.
Yes, sir.
So you are saying this.
Yes, sir.
Okay.
Experience says that when you have effusion in a joint, in a case of osteoarthritis, usually it is related to some overactivity or kind of a trauma or sleep or like that. They always attribute that effusion to that trauma only, usually. Why should there be effusion without a reason in osteoarthritis? So as he said, it is basically non-inflammatory problem. Inflammation, whatever you see in the synovitis or whatever, is usually due to some overactivity. Like I traveled some distance, keeping my knee like this, either overactivity or kind of injury like sleep of leg or all. So inflammation is not actually a characteristic of osteoarthritis, but associated some overactivity like that. This is what my impression is. That leads to effusion.
Okay, thank you. Now I invite Dr. Dushyant Chaudhary. We have 8 minutes for presentation and 2 minutes for discussion. Functional assessment of single bundle reconstruction of ACL by autologous hamstring graft.
Good morning, everyone. Today I'm presenting my research study on functional assessment of single bundle reconstruction of anterior cruciate ligament by autologous hamstring graft. Arthroscopic anterior cruciate ligament reconstruction is common surgery in orthopedics. ACL reconstruction improves stability and function of knee and reduces the risk of long-term cartilage and meniscal injuries and delay the onset of tibiofemoral degenerative arthritis. A wide variety of techniques and graft types are now available for reconstruction of ACL. Hamstring graft is commonly used with excellent results. However, varying opinion exists among experts with regard to the ideal technique and graft to be used. Arthroscopic ACL reconstruction using hamstring autograft with fixation in the femoral tunnel using endobutton and in the tibial tunnel with interference screw is a literature proven excellent technique. Objective of these studies are to review the functional outcome of single bundle ACL reconstruction using hamstring autograft. Material and method. Patient with complete ACL tear who satisfy the inclusion criteria attending orthopedics OPD in School of Medical Science and Research. The sample size is 20. Study design is prospective study. Duration of the study was July 2019 to December 2020, 18 months. 20 patients with ACL tear on the basis of inclusion and exclusion criteria were taken. Arthroscopic ACL reconstruction done with autogenous hamstring graft. At final follow-up functional assessment was done according to Lysholm and Tegner knee scoring system. The inclusion criteria was age was taken 20 to 50 years, 6 weeks to 1 year post injury, MRI confirmed ACL injury, unilateral ACL injury, positive anterior door test, positive Latchman test, patient willing to follow post-operative rehabilitation protocol. The exclusion criteria were generalized hyperlaxity of joints, previous ACL surgery of either knee, evidence of multiple ligament injury, previous knee surgery, ligamentous injury to contralateral knee, grade 2 and 3 arthritic changes in the knee. Examination. Patient were subjected to careful history taking and full clinical examination, including anterior draw test, Latchman test, McMurray test, pivot shift test, posterior draw test, valgus stress test, and varus stress test. Radiological examination was done using X-ray and MRI of affected knee. This is the X-ray showing pre-op X-ray of the patient. This is the MRI. Now the surgical technique: harvesting of autologous hamstring graft and preparation of the graft for fixation, creation of arthroscopic portal entry into the knee joint, creation of tibial and femoral tunnel for fixation of graft, application of graft through the tunnel created and fixed with endo button in femoral tunnel and with interference screw in tibial tunnel, with or without post-tibial stapler. And this is the photographs of graft harvesting. Now the results, and total number of patients were 20. Study design was prospective study. Sampling design was convenient sampling. Data analysis. Follow-up was done at 6 weeks, 12 weeks, 6 months, and 12 months. Outcomes were measured by using IKDC and lysome score. The minimum age was 23 years and the maximum age was 49 years. The average age was 34.85. This is the graph showing IKDC and lysome score. Pre-op it was 27 and 32, and after post-op it's on 6 weeks, 12 weeks, 6 months, and 12 months, shows excellent outcome. The functional outcome post-operatively was also excellent. This is these are the pre-op and post-op radiographs. Discussion: the ACL has poor potential for spontaneous healing when it is completely torn. 2/3 of patients develop knee instability following injury to ACL. Surgical reconstruction is the gold standard for the treatment of ACL injury in sportsmen and young individual in achieving high rate of success in terms of recovery of normal knee function and return of pre-injury level of activity, and delays the onset of osteoarthritis. The type of graft surgeons choose to reconstruct the ACL has changed in recent decades. Erickson popularized bone patellar tendon autograft, as first described by Jones on 1960, but due to site morbidity and post-operative stiffness, makes surgeons to look at alternative graft selection as hamstring tendon graft. In 2017, Chen et al. Conducted a meta-analysis and concluded that the outcome of single bundle ACL reconstruction with AM technique is better than the transtibial technique in terms of stability and functional recovery of knee. In 2018, Mayer O'Herman et al. Concluded a study on 64 patients and concluded that at the 5-year follow-up, no advantage for either the double bundle or single bundle technique in ACL reconstruction can be seen with regard to patient-related objective outcome measures. In our study, we found that ACL reconstruction with single bundle hamstring graft holds good in patient with ACL tear, with excellent functional outcome in 15 patients and good outcome in 5 patients. No graft failure was observed in our study. Limitation of our study was small sample size, small follow-up time frame, and unicentric study. The conclusion of the study was arthroscopic ACL reconstruction with autogenous hamstring graft gives high success rate in terms of functional recovery of patients. Thank you.
Okay. Thank you, Dr. Dushyant. Nicely presented. Any questions from audience? I want to ask how you assess the functional results in these patients in single bundle.
So we use lysome and IKDC scoring system, in which many criteria are there, like climbing stairs, squatting, and doing routine walk, walking, running. These are there in this.
When you allow in such patients the high energy activities?
Sir, after 9 months.
After not after 6 months, 9 months.
Yes, sir, 9 months.
Any specific reason for that?
Sir, it's our in post-op rehab protocols. We after discussion we set it to 9 months.
Because in ACL reconstruction, usually after 6 months, we allow the patients for the high energy activities. Usually these patients are high demanding patients in sports injuries. So they need for early return to their field. That's why Okay.
Yes, sir. In our studies, sir, we take 9 months for full contact sports activities, for high energy activities. We
After 9 months.
Yes, yes, sir.
Okay. So now I do invite
Thank you.
Dr. Satrik Mukherjee, management of posterolateral corner instability of knee by modified Laparade technique.
So do I start? All right. Very good morning to all of you, our respected chairperson, the delegates present here. I am Dr. Shultrik. I'm from North Bengal Medical College, and I'm here to present the work that we've done regarding a modification of the conventional Laprade technique to reconstruct the posterolateral corner injuries. It's not changing, excuse me. Slide is not changing. All right. To begin with, what basically is the posterolateral corner? Like, for example, it was almost until 2003 that until like Dr. Laprade shed some light on the anatomy, it remained a dark corner of the knee. The PLC basically comprises of multiple important stabilizing structures, but when we are focusing on reconstruction, we are basically targeting at the three static stabilizers. They are the fibulocollateral ligament, the popliteus tendon, and the popliteofibular ligament. Now, why PLC? Like, why it needs to be addressed? Like, for a long time, as I've said, like people were not aware of the posterolateral corner injuries, and they only reconstructed the cruciates and the menisci and the collaterals. Now, it was seen that PLC injuries are rarely isolated injuries, and they're mostly associated with like cruciate injuries. So, if they are not looked after, and we are only addressing the cruciates, it often becomes a potential cause for graft failure in cruciate reconstructions. And also, an unaddressed posterolateral corner injury, it leads to a persistent posterolateral instability, leading to a varus thrust gait, leading to increased incidences of medial compartment osteoarthritis and medial meniscus injuries. So we had this series of 10 patients who were previously operated for either anterior or posterior cruciate ligaments, and they were presented to us eventually with the instability of the same knee. And upon evaluation, we found that a grade 3 PLC injury was found to be associated with this instability, which was perhaps missed previously. Now, in our study, we have incorporated two special tests of PLC for the objective clinical diagnosis, the varus stress test and the dial test, and one radiological parameter of assessing the how much of lateral gaping is present on varus stress views of bilateral knees. So coming to the procedure, like on table, we reconfirm our diagnosis under anesthesia with the dial test. As you can see, there is a rotational instability as well as varus laxity is present. We position the patient supine, and we give a like inverted hockey stick incision from between the Gerdy's tubercle and the head of fibula. And the first thing we do is we create a posteriorly based flap, and it needs to be a thick flap to ensure the vascularity of the skin and subcutaneous tissue is not hampered, followed by the dissection of the common peroneal nerve. Now, this is very important because one of the most dreaded complications of this procedure is a CPN palsy leading to a foot drop. The first window we create is by splitting the iliotibial band. We expose the lateral femoral epicondyle. Now, this is important because this is where we intend to create our femoral tunnels for the proximal attachments of the PLC structures. The first tunnel that we do is a fibular tunnel from the anterolateral aspect of the fibular head to the posteromedial styloid. We rim it, and then we place passing sutures for facilitation of passage of future grafts, as you can see. After that, we create like there you go, the passing sutures are being placed. Then we create the tibial tunnel from just lateral to the Gerdy's tubercle from an anterior-posterior direction. And similarly, we place passing sutures over there as well. Then we shift our attention to the proximal attachments. As you can see, the remnants of the popliteus tendon and the FCL have been tack stitched to locate the exact location of where we intend to create our femoral tunnel. In our case, as you can see, we have done a single femoral tunnel. Now, this is the modification that we've done. In conventional Laprade technique, there are two femoral tunnels. Now, why the modification? I'll be coming to that later. We create the single femoral tunnel, and we have used split quadriceps tendon graft in our series. with a single proximal limb, which serves the common attachment site for both the popliteus tendon and the fibular collateral ligament. As you can see, the graft being secured in the femoral tunnel, we fix it, and the two distal limbs serves one as the FCL, one as the popliteus tendon. The FCL limb of the graft is taken from behind the iliotibial band, passed through the fibular tunnel from an anterolateral to a posteromedial direction, and the remnant of that, along with the popliteus tendon, is taken through the tibial tunnel, and it is fixed with the knee in about 60 degrees of flexion, foot neutral rotation. After that, we like post-operatively we check for, like on table we check for the stability, and then it was okay. Now post-op, we have follow a very strict rehab protocol which begins from day one itself, mainly focusing on the quadriceps functioning, the tibiofemoral and patellofemoral range of motion exercises. We have a target of achieving about 90 degrees of knee flexion at the end of 2 weeks. We begin with partial weight bearing with accelerated crutches from 6 weeks onwards. Like full weight bearing, like when the patient can bear weight without pain, we go for closed chin strengthening exercises. This is the rehabilitation summary in all. Okay, coming to the analysis, we have a functional analysis, clinical as well as radiological. Functional outcome was analyzed with pre and post-operative IKDC scoring, clinically with the two clinical tests that I've already mentioned, the dial test and the varus test, and the radiological effectiveness with how much of the varus gapping is corrected. Now we found that like all the patient had negative dial test as well as varus stress test even at 6 months follow-up. The functional IKDC score, there was a drastic improvement, about say from mean 39.53 to 81.39. And radiologically, all the varus, like all like 10 of 10 patients, they had a correction of the varus gapping. However, one of the patient developed CP and neuropraxia leading to a post-op foot drop, which recovered at 12 weeks. Now we see that the modified Laprade technique actually demonstrated a pretty improved subjective and objective patient outcome, and it was almost equally effective as the Laprade technique to restore the near native varus and rotational stability of the knee. So like what do we take home? Like firstly, we must be very vigilant in diagnosing PLC injuries, because as I've mentioned, if missed, they become a potential cause of graft failure in the cruciate reconstructions. Now, why the modification that we've done? Like in these patients, if you're doing a conventional Laprade with two femoral tunnels, now it must be remembered that these patients need a concomitant ACL and PCL revision surgery as well. So with a single femoral tunnel, we are facilitating much lesser chances of firstly femoral tunnel coalitions, and secondly, a single femoral tunnel will preserve much more bone stock, so lesser chances of stress fractures. So we can like suggest that like this is not a like comparison between which is better, like modified Laprade or conventional Laprade. Obviously the conventional like stands as the gold standard, but however modified Laprade technique is a viable approach in patients who have had a failure of prior ACL PCL reconstructions due to a missed PLC injury. Thank you.
Nicely presented, Dr. Sotrik. Now questions are open. As you I'm asking something for sake of knowledge. You used both limbs distally after creating the femoral tunnel, one passing through the fibula and the other one is from the tibial tunnel.
Yes, sir.
Okay, so you use the absorbable screw in those cases?
Yes, sir.
Titanium screw can be used for that without any difference?
Yes, it could be used, sir.
It could be. And
Yes.
in femoral tunnel?
Femoral tunnel, yes, sir. Like basically, the titanium screws for the fibular tunnel, we are using a 722 wire screw. It is not used. The titanium screw is usually not available of that size.
Those
sir.
sizes.
Yes, sir.
Okay.
That's right.
It was a nice presentation.
Thank you,
I
sir.
congratulate you. So now I invite you, all of you, I invite for the valedictory function. It will start from 11 up till 11:30. And after that, we are again gathering in the same hall for the further session. Thanks for your presence. I congratulate to all the participants. They tried very well presentation, and we encourage them for further.
Important person for me than others because he's gonna do an audit. And then thereafter, I would quorum is complete. Now I would request Dr. Atul to
You've been listening to Arun since the last 3 days, and he's been conducting the Hall A. Conducting the Hall A singularly is a task in itself. And congratulations, Arun, I would like to take you to take your seat as the organizing secretary of the Mini IOCON 2020.
thank you, sir. Thanks a lot.
Dear friends, thanks once again that all you are here and being with me in this difficult and such crucial period where nobody want to come out from the house, but you are out of the house and with me in this audience hall. I request one by one from the all 5 zones to say and give their feedback and observation about this conference, whatever their feelings, so that we central zone, Dr. Saket from central zone, because Dr. Teddy Tewari and Akhilesh has left hall, their flight
Saket,
was
you can
at 12.
speak from there. You have a mic there.
Thank you, Meena sir. It has been a privileged pleasure to be here in Mini IOACON 2020 at Jaipur. After having had a tough time from March 2020 till date, I believe it has been a wonderful and very personalizedly organized conference where most of the people, orthopedic surgeons who have come here, they have so much of positive vibes. I believe this is remarkable. And thanks a lot to the team of Dr. R.C. Meena sir and Dr. Arun Sharma. And heartiest congratulations to the President, Dr. Shivashankar, Secretary, Dr. Naveen Thakkar, the Vice President, Dr. Atul Srivastava, the Treasurer, Dr. Sandeep Kumar, and the Joint Secretary, Dr. Pradeep Bagecha. I convey the gratitude to the organizing committee and IOA officials on behalf of Central Zone. Long live IOA. Thank you so much.
Thank you very much, Saket. So nice of you, my friend. Now, representative of the East Zone, Dr. M. Ray, sir. Dr. Parth. Yes, sir. M. sir.
मैं क्या बोलूं? Professor Meena, Dr. Arun Sharma, and the IOAC dignitaries, Dr. Atul Srivastava, Dr. Naveen Thakkar, and Treasurer Sandeep Kumar, and Dr. Simply, I could not imagine that such a mini conference could be held. I had the information before, but when there are a lot of oppositions, and I found simply it cannot be done. So I give up the hope that it is not possible to attend this conference. But however, whenever I contacted organizers, they said, Arun particularly, and Professor Meena sir, yes, it will be done so easily. So I had to have the ticket. Just in the last moment, I purchased the ticket and got it. And I find this is a unique one. And in even the odd time, in this pandemic situation, they have done it, and it is materialized and fine. And I find a lot of interested people, even our Professor Tuli has come here, and a lot of from Mumbai and others. I really salute the organizers for such a brilliant conference. Thank you, sir.
Thank you very much, sir. Ray, sir, we impressed with your kind words. And now I request from the South, Dr. Mallikarjun, sir.
Thank you, sir, for giving the opportunity to express my views. Dignitaries on the dais and off the dais. I can tell you the story of Mini IOACON, how it happened. It happened because of the grit and affections and positive mind made this conference to happen, actually. And of course, whenever you attend the EC meeting of IOA, we are all positive mind people. To definitely should happen. And a couple of times I discussed with President R.C. Meena and incoming my friend B. Shivashankar also. We are all positive actually to attend this. But within a short time, short notice, you have conducted a beautiful conference. I think it's one of the wonderful things you have taken in a positive way. I think I congratulate on behalf of South Zone. Thank you, sir. Thank you very much. Long live IOA.
Thank you very much, sir. So nice of you. I request Dr. Tuli, sir, as a representative, of course, your stature is much higher than the zone. You are the symbol of the whole ION country of the fine brain orthopedicians. But I request you as a North Zone representative, please give your valuable words.
The
and kind words.
way you are making me come to the speaking area, probably you are spoiling me. That's my feeling, that you are spoiling my habits. Probably difficult to spoil at this age. Everything is fixed already.
Thank you.
My friends, as our association provides us an opportunity to listen to the work being done in the country. Same problem, multiple solutions. That's the beauty to listen to. A disease of the hip joint can be treated by operation, remove the bone away, or reconstruct the bone. So all this one can see, there are so many methods of treating the same condition, and that is what you learn sitting in an organization like this. These associations and meetings, they do serve the academic purpose, but they also serve the social purpose. We are social animals. We are human animals, but we are fortunately social animals. We also learn how to tolerate each other. Somebody has a different way of expression, the other person has a different way of expression. We learn how to tolerate all this. We are a part of a huge family with multiple generations. Developing generation, developed generation, and probably the super senior generation. Let's learn to live with each other, interact with each other, look at each other, recognize each other, and maintain a large social family and a large familial feeling and a get together. I wish all this is continued for future years. The organizers have served to provide all these facilities in this conference. Probably I have been overexposed in this conference, though I'm a backbench sitter, but today, this conference, I have been sitting all the time in the front line. Thank you very much.
Thank you very much,
Professor
sir.
Meena.
So
Thank
nice of you for your kind words. I request Dr. Kanabar from the West Zone. Of course, his stature is much higher than the West Zone, but today we have an opportunity to listen something from him for this conference as representative of West Zone.
Good morning, Professor Meena, Dr. Shiva, all the dignitaries on the dais and my friends over here. Something will happen, will not happen, went on happening for a long time in IOA. It's a very sad year that we had pandemic from March. And probably the academic activity in person completely stopped. We had webinars and we had talks digital, but whatever happens together and what sir mentioned about social, which is very important, and that is what could happen. So I would like to thank Professor Meena and his team and all the executive committee member of 2020 who agreed upon to have this mini IOACON, and it has happened wonderfully. Sir, you have done everything, all academics, they were there, all socials were there, wonderful evenings were there, get together was there, and this was something what any orthopedic surgeon wishes to attend to. I'm very happy I came here. I'm very happy you did this conference, and it is done in a wonderful way. I want to congratulate you, Professor Meena, and your team, Arun, everybody. You have done a wonderful job. Thank you so much.
Thank you
I
very much,
highly
sir.
appreciate.
Thank you, so nice officer. And a representative from the Naroza, Dr. Satyajit.
Respected Meena sir, Shiva Shankar sir,
Atul Srivastava and Naveen Thakkar and everybody in the dais. At one time, we never thought of this conference, and I feel really proud that the IO has gone forward to organize this event in this difficult time. This pandemic has changed our social attitude and behavior, which is obvious everywhere. But in spite of that, I really congratulate Meena sir and his team for nicely organizing this event. Though it is termed as a mini IOCON, except for the smaller gathering, we have never felt it is not like an IOCON everywhere. It's good socialization and good academics also, excellent academics. Though number of halls may not be 6, 7 halls, we are having in 4 halls, but it's excellent academics, sir. I must admit, and definitely we enjoyed it. And my greetings to everyone from Northeast. And I especially am lucky to see people like Professor Tuli sir, Kanabar sir, Yadav sir, in this difficult times amongst us. Sir, wish you all good health and future. Keep blessing this IOA and IOA members in future like this, sir. Thank you so much.
Thank you very much, Satyajit. Now in the last, I request Dr. S.S. Yadav, sir, as an expert opinion and blessings on the behalf of past president for this conference. Sir, please say what is your feeling?
Dignitaries on the dais, my colleagues, young orthopedic surgeons. I'm very happy to be here for the last 3 days to enjoy this great get-together. Conferences, ordinary conferences, usual conferences are held every year towards the end of the year. But this year, as you know, unfortunately, we had COVID-19 from March, and the whole year was passed in a sense of instability. Instability, I use the word because there was a sense of negativity. There was a sense of negativity throughout the year, whether the IOA conference will take place or not. And in the beginning, majority of the people wanted that it should not be held. It was considered, reconsidered, and again considered that some sort of a meeting should be held. Why some sort of a meeting when we can well call it a IOA meeting? Some of the colleagues said it should be named as CME. Why? Why degrade IOA? I could not understand why degrade IOA and why call it a CME or any other ROSA conference. No, it should be called as IOA conference. And final outcome after various meetings and meetings and meetings that a mini conference should be held in Jaipur. And let me pat the back of Dr. R.C. Meena and his team, Atul Sharma, a dynamic trainee of Dr. Meena, who is coming up, and you will see him coming up in a couple of years. He will be occupying the central chair. So give him a clap, yes. So finally, it was decided that a mini conference should be held in Jaipur. Ladies and gentlemen, it was a task to hold the meeting in 3 months' time or 2 months' time. Till the last moment, Dr. Meena did not know whether the conference is going to be held or not, be it a court case, be it the circumstances under which we were working. But finally, it was finalized that the conference shall be held. And as various people have expressed their views before me that it should be rated, it will be rated as one of the best conferences of the recent times. And the credit goes to Dr. Meena and Dr. Sharma. I must appreciate the support of Dr. Shiv Shankar, who always said, yes, sir, we can hold the conference. We can hold the conference. And I must appreciate dear Atul's efforts from Agra that the conference was finally recognized and to be tabulated towards the end of the year. And it is one of the best conferences to be remembered. Last, I would like to appreciate and thank the ladies of these great people in Jaipur who have spared their husbands to work day and night to make this conference a great success. I do not know if Mrs. Meena is there in the crowd, but I will request Dr. Meena officially to thank Mrs. Meena and all other members of the team to thank their wives who have spared their great husbands to make this conference, to work day and night to make this conference a great success. I think I have no other words to say that, ladies and gentlemen, it is done. A very important point, which I have been saying in the meetings also, and I'm happy that the organizers had taken that point, that 65th number would have been missing from the armamentaria of the IOA if this meeting was not held. Tomorrow, after 10 years, 15 years, when the youngsters will count 1, 2, 3, 4, 63, 64, 65 किधर है? 66 बॉम्बे, 65 नहीं है. कम से कम अब इसके बाद 65 नंबर आ गया है. That 65th conference was held in Jaipur and with great vigor. Thank you very much.
Thank you very much, sir. As you told, no word, but the whole house knows that you are the dictionary of many fine words. And it is very difficult to select the fine among us, the fine, and that you have done wonderfully. So nice of you. So now I take opportunity to give my summary of tenure with the permission of the dais and the house dignitaries on the front. Mike, yes. So good morning, the friends in the house. Dr. Shiv Shankar, President, IOA, IOACON 2021. Vice President, Dr. Atul, Secretary, Dr. Naveen Thakkar, Treasurer and past Zone Secretary, Dr. Sandeep, Dr. Pradeep, my friend Arun, and the three Dev, Brahma, Vishnu, Mahesh sitting in the front of the row. Many seniors, my senior friend, Dr. Sinde, Dr. Swami, Dr. R.C. Bansibal, Dr. Daima, and industry's colleague as well. Friends, I started to work as a part of president since past vice president, president-elect, and as a full president in the year 2017. Elected in 2017. And till that, I did my try best to serve the IOA and give the best honor to the IOA in different capacities. If you see at my personal level, I collected 15 to 20 lakhs in the year 2018 for the IOA services as a personal capacity. Again in the year 2019, 15 lakh, and in this year of difficult period, 20 lakh, 15 from the IPCA, 3,000 from other agencies. And similarly, whenever the physical meetings were not possible, I started IOA PG teaching program so that the new words and the new generation can be benefited. And all the members, those who could not join the meeting physically on the initial March, I joined it on the online 19th July 2020. In that meeting, the whole house unanimously gave me mandate to continue as the president up to the end of the 2021. But as the corona is an endless problem, we cannot predict what another corona may come. And to uphold the value and the image of our constitution and association, I decided on the 11th December to organize a IOACON at Jaipur so that all constitutional formalities can be done with the orations, official valedictory function, and for that, unanimously more than 80-90% CWC, CSRC members give consent on the WhatsApp group. That is a valid information. What some people again object that this is not a physical meeting. This is not a real mandate. In that, दिमाग में ख्याल आया, पलट देते हैं हम मौजे हवादिस, पलट देते हैं हम मौजे हवादिस अपनी जुर्रत से कि हमने आंधियों से भी चिराग अक्सर जलाए हैं। इसके बाद में लोगों से पूछा, भाई चाहते क्या हैं आप? व्हाट्सएप पे मैसेज छोड़ देते हैं कि डॉक्टर मीना गैर कानूनी रूप से कॉन्फ्रेंस करना चाह रहे हैं, उसको तो आप सराह देते हैं, देख लेते हैं, लेकिन जब कानूनी रूप से आपके 76 आदमियों ने, मेंबरांस ने कंसेंट दी, कॉन्फ्रेंस कराई है, उसको लोगों ने माना नहीं। कोई बात नहीं, फिर भी हमने आंधियों में चिराग जला करके डॉक्टर शिवशंकर ने कहा कि हम एक गूगल सर्वे कर लेते हैं। यू वॉन्ट बिलीव फ्रेंड, 95% persons out of total survey, only 3 went against this conference. Only 3. Again, the question raised, sir, how it can be possible? Google survey is not valid and it is nowhere mentioned in the constitution, but they do not think. Intelligent persons say that glass is half full of water, but the sick mind person say that it is half empty from the water. It is their own problem. Anyway, then we decided to have a AGM to get the consent for this conference again. And in that conference, how so many numbers it joined? The again 90% persons gave yes, this conference held to be at Jaipur in a proper protocol and manner. And ultimately, we come to organize this conference. So, दोस्तों, मुझे वो महाराणा प्रताप वाली एक कविता याद आती है, हूँ लड़ो घण्यो हूँ अड़ो घण्यो, राजस्थानी है ये, हूँ लड़ो घण्यो हूँ अड़ो घण्यो, मेवाड़ी मान बचावण ने, पर लाज नहीं राखी रण ने, बेरारे खून बहावण ने। महाराणा प्रताप ने, आपको सब जानते हैं, वो वीर शिरोमणि राजस्थान के सितारे थे कि उन्होंने अपने देश की आन बान मान शान बचाने के लिए पूरी जिंदगी में हर तरह के कष्ट सहे, और उससे कम कष्ट मैंने भी साल भर एसोसिएशन को मेंटेन करने में नहीं सहे। अगर आप देखें तो आप डे टू डे की लाइफ में देखते होंगे कि मैं 10 कदम चलता, 2 कदम चलता, लोग पीछे से कोई पैंट पे पकड़ लेता, कोई जूते चप्पल पकड़ लेता, कोई कोट पकड़ लेता और 10 कदम पीछे ले जाता। इस हालात में मैंने किस तरह से इस मुकम्मल प्रोग्राम को अंजाम दिया, लेकिन हमारी एक बहुत अच्छी एक किताब है, उसको लोग महापुराण भी कहते हैं, जिसको गीता कहते हैं। उसमें लिखा हुआ है, उद्यमेन ही सिद्धायन्ति, उद्यमेन ही सिद्धायन्ति कार्यानीन मनोरथे। यदि आप उद्यम करते हैं, कार्य करते हैं, आपका अवश्य सफल होगा, आपका मनोरथ पूरा होगा, ईश्वर आपको जरूर सफलता देगा। इसी तरह से अगर आप जरा सा भी हौसला रखते हैं, निगाहों में मंजिल हो, गिरे और गिरकर संभलते रहो। हवाओं ने कोशिश भी की थी, मगर चिराग आंधियों में भी जलाकर हमने दिखा दिए। थैंक यू वेरी मच दोस्तों, आप लोगों ने मेरा साथ दिया। इन द लास्ट मैं कहना चाहूंगा कि इस डिफिकल्ट पीरियड में, जहां पर कि मैंने रजिस्ट्रेशन फीस आपसे 5,000 6,000 के बीच में रखी थी, इस होटल का एक खाना 1,800 रुपए का पड़ता है। लेकिन मेरे इंडस्ट्रीज कुलीग जिन्होंने ये आंख मीच करके कितने लोग आएंगे, कहां से आएंगे, आएंगे भी या नहीं आएंगे, आंख मीच करके ये कह दिया। Among them, few I enumerate to name that one is Ipca Pharma, Triaco Pharma, Tionor Orthotics, Elanger, MacLeod, Alchem, Omnicurus, Zydus, and many more are there. I'm sorry not able to take the name because these are a big list. But again, I was shocked to see in the last, sir, that many nefarious persons write letter to the bank, don't open this account, this is illegal conference, and the bank manager passed that letter to me on a mail, and he write in the footstep that, sir, don't disclose my name, it is very confidential and very financial. And not only he write to the manager of the bank, he write to the all top GM of that bank. And he started a series of the letters and the mails daily to all dear industries, colleague, friends. See the version of our president that this conference is not constitutional. Don't participate. Think twice before participate in this conference. But thanks to my industrial colleagues, they send all these papers in the dustbin and ask the sweeper that don't sell them at the rate of 10 rupee per kg as a raddi paper. Rather, he said dump them so that they doesn't come in front of the next coming president or leader of this association to malign the image and disturb unnecessarily those who want to do something for this association. Thank you very much, friend. Have a nice day. And my faculty, Dr. Daima, Dr. Bansiwal, Dr. Arun, Dr. Abhay, in my absence, Dr. Rajan took my charge of my unit, worked day and night 24/7. Okay. Yes, Narang Sahib.
Good morning, everybody. I'm R.K. Narang from Melangers. I could not resist coming on the stage or just to say a few words because I heard everybody saying about the conference and I wanted to put a few words from our organization and on behalf of the trade industry. Sir has already named the participants of the industry. I just wanted to add that I heard the Central Zone, North Zone, West Zone, South Zone, all of them have said adequate words that yes, this conference deserves a big clap. Please clap. And I, on behalf of the industry, would definitely say that we had full trust in Dr. Meena.
Thank you very much, Narang
Whatever
sir.
he said just now, it's a true fact that we have received such WhatsApps also, but we did not care for it because we trusted it and we are very happy that we have participated and lived up to the trust of Dr. Mini.
Thank you very much, sir. Narayan sir. Thank you very much, sir. On a single call he came, not repeated call. Just I called Narang. Yes, sir, we are with you. Thank you very much, sir.
So sir, let the exchange of jewel happen. This was the key event of this conference. So ladies and gentlemen, we are here for this final moment of the final event. This is the exchange of jewel and change of guard ceremony of Mini IOACON 2020 65th Indian Orthopaedic Association meeting. And we are no need of introduction, but we are introducing our new dynamic, humble, jubilant Dr. V. Sivasankar. It takes a lifetime to become a president. When Manchester United introduce Paul Pogba or any football player, they make a conference, they make a hue and cry. Then why can't we organize it?
Congratulations, congratulations, congratulations.
This is the proper event. This is the proper way. It takes a lifetime to become a president. And not everybody is so lucky to become the esteemed president of this 30,000 plus members fraternity, which is rubbing shoulder with best of the best, AAOS, BOS, everywhere they are. So, sir, I guess
coming to that, there is also an outgoing president's medallion. I would request Dr. Shiva Shankar, President IOA 2021, to hand over the outgoing president's medallion to Professor R.C. Meena, President 2020.
So first time from the Rajasthan, we had a president. From the land of Sangaj or Ranaj, we have finally a president. Now I invite the new president of Indian Orthopaedic Association, Dr. Shiva Shankar, to share his plan for future. Sir.
Immediate past president, my elder brother, Dr. R.C. Meena. Vice president, immediate past press secretary, Dr. Atul. Incoming secretary, Naveen. Incoming joint secretary, Pradeep. Incoming treasurer, Dr. Sandeep Kumar. Organizing secretary, the name I gave yesterday to my friend Arun. Senior sitting in the hall, past president, Professor Dr. Tuli, Dr. S.S. Yadav, Dr. Kanabar. Ladies and gentlemen, friends, it's customary for the new president to give a theme in the last decade. It was not there before 2011. If I am right, Dr. Rajshekharan started giving a theme. This time, I am changing a bit. I am not only giving a theme, but I am also giving a logo for the year 2021. My presidential theme for the IOA for the year 2021 will be, please welcome my presidential theme. It's Atmanirbhar Orthopaedics, Indian at heart, global in competence. It's Atmanirbhar Orthopaedics, Indian at heart, but our skill should be global and second to none. Coming to the theme, Atmanirbhar Orthopaedics, that's the first part, and the second part is Indian at heart and global in competence. As I said, I have a logo as well as a theme. Let me come to the first part of the theme, that is Atmanirbhar Orthopaedics. It represents that we are self-sufficient as far as orthopedic as a whole is concerned. We are Atmanirbhar in every aspect of orthopedics. We train our young surgeons in such a way that they need not have to go abroad to acquire skills. We have a lot of knowledge in our own country, but unfortunately, we don't have a systematic way of training our young people. So that's one of the area where I want you all to work. We all know, or you all know, that we do get medical tourism patients from abroad or across the globe. Our standard of treatment and patient care doesn't require to be talked in front of you. So we are Atmanirbhar in that respect. Unfortunately, our young generation keep going out for training because we don't have a structured training program in India. And also the stipend they get is meager. So they better go elsewhere where they get better stipend. That's one of the reasons. So that we have to work on that. My wish is also that we should also become not only Atmanirbhar in soft surgical skills like the orthopedic surgery, but also in hardware related with our practice, like the instruments, implants, CM machines, machinery required, implants we are using. Everything should be of global standard and it should be available. We have many Indian companies, they supplied to the world. They have CE certified, FDA, US FDA certified implant. They are manufactured in India. Unfortunately, they are not available to us. So I request all of you to be Indian, buy Indian, and promote Indian. Yes, we should not compromise on the quality, friends. Just because to save few $100, we should not use a substandard implant. Only if we promote good quality implant and start purchasing them, then only this our trade partner will also improve. Instead of only supplying it to the world, they also will start supplying to us. Coming to the next part, Indian at heart, that's the first part of the second part. Global incompetence is the second part. What is Indian at heart? Friends, you all know, yesterday Dr. Yadav was telling, for tibial and fibular hemimelia, BK amputation is not the treatment of choice which is recommended by AAOS. Our Indian patient refused the treatment of amputation and a prosthesis. That's the standard protocol there. Our customs are different. Our requirements are different. Our faiths are different. Our culture is different. If I advocate for a fibular hemimelia or tibialia amputation, if there is a sensation in the foot, none of our patients take that as an option. Also, India is a unique country where treatment is decided not only by the protocols, but also by the economy. If an elderly patient in the family has a hip fracture, the son or daughter thinks, is it worth spending ₹1 lakh to get him operated or let him die? They save money for marriage, but they'll never save money for medical treatment. When you go to a shop, we buy a mobile, we give ₹50,000, but in my hand, I can come and show I have got a mobile. But if they come to my hospital with a fracture, can they go out and show off their fracture? I had a very bad fracture, it has been fixed. Nothing they will get. That is the problem we have in India. So that has to be taken care. So our heart should beat for the benefit of our patients and our society. We, as I said, have a unique problem. We should have empathy for our patients and we should take decision in the best interest of our patient, considering their socio-economic and cultural aspects too. This is what I want to, by meaning Indian at heart. Coming to global incompetence, as I said earlier, we are second to none. We are one of the best because we do get complicated cases. Our skill as orthopedic surgeons should be second to none. We should learn and implement newer technologies, and we should always be ahead of time. Experts should impart good training to young aspirants. The young trainees should also get assured amount of as a stipend. That is one of the main reasons, because medical education goes beyond 30 years of life. How many days our young generation can sustain with a family with such a paltry amount as a resident he gets? So we should also increase our stipend, which are commensurate with the age and experience. India should be the preferred destination for medical tourism, as I said earlier. Coming to the theme, what this theme has, there is a hand which covers and protects the IOA logo. We are one family under the banner of IOA. That's what the hand says. We shall protect the interests of our members first. We shall work for the benefit of our members first. There is another hand which supports the Indian Orthopaedic logo. This logo, this hand says, we care for IOA. We want to support IOA. Our motto as members of IOA is to serve the patients with proper care and empathy, and to give a healing touch to our patients. Lastly, there is a tricolor in the background, the Atmanirbhar India logo. Tricolor in the background says, I am proud to be Indian. Mera Bharat Mahan hai. We are proud to be a member of Indian Orthopaedic Association. We shall give due credits to our own Indian studies done by our own friends. We all quote foreign references when we give our talk. Why can't we quote our own papers? We have the greatest of the tuberculosis person sitting in front of us. Middle path regime has been given to the world by Dr. Professor Tuli. Fibula graft has been given to the world by Dr. Yadav. Dr. Kanabar is the first person in India to do the arthroscopic surgery and teach so many people how to do on an Indian patient. We have such stalwart sitting. Why we should be quoting something else? Why can't we quote Ganga Hospital score? Why we should only quote Gastillo Anderson score? We have so many studies done by us. Unfortunately, we ourselves don't quote our people. That should stop. We should proudly acknowledge the innovations done by our own colleagues. We shall project IOA in a global platform in a better way. We want to promote more indigenization in orthopedics, especially in implants and instrumentation, to cut the cost. We all proudly say that I only use imported implant. I never use Indian implant. That should stop. Friends, 99.9% of my implants are Indian implants I've been using. If I use any imported, it's only replacement surgeries. I want there also to use an Indian implant. Unless we promote our own companies, they will not come with a good quality implant. The people who do it in large numbers should promote such companies. They should be used properly. We want to promote more indigenization in orthopedics. India should be most prepared medical destination for medical tourism as far as orthopedic is concerned. Coming to my vision for IOA, there is nothing new. Whatever I had done 3 years back as my vision for IOA, I have not changed even a word from that to enhance membership. Friends, that's the reason why we have given a chance for all to become member before 31st of March, so that you will be ratified and you will be able to vote in the next election. My vision for the young orthopedic surgeons: institutional subscription of JBJS, ACTA, and other major journals, and with all archives can be accessed to all the institution will be to be supplied from IOA side. To increase the create pool of various fellowship and jobs available to coordinate through IOA, chart out path including minimum stipend to be paid. Because I do get so many young people asking, sir, I want to do this fellowship, where I can go, how much I am going to get. So many messages I keep getting. Friends, Dr. Ram Prabhu started this very good program, your mentorship program. I want to continue with that program, which is very, very useful to train our next generation. Because there is something which is, when I am senior and I require orthopedic treatment, I require to be treated by a good surgeon. That's the reason why I want to train our young surgeons so that we will be in the best hands when we require them. The next one is to enhance skills and academics through virtual classes, and also to help members to publish their data in reputed journals. Already we have started doing this. In the Corona time, we have published a lot of data from India to promote research in day-to-day medical practice by organizing various workshops all over India. We shall have workshops on this topic of writing papers and research all over India. Friends, as I said earlier, during Corona time, we have conducted so many webinars. I myself conducted as a moderator more than 50 webinars. There is a lot of pool of data available, and that can be used without any problem by any member at any time. They are all available on our IOA website already. Friends, the next one is austerity drive. Money saved is money earned. To curtail unnecessary expenses on various meetings and day-to-day running of the office. Friends, we had last month only EC meeting on the Zoom and EC meeting GBM on the Zoom. What has costed this to IOA? Only a few thousand rupees to get the Zoom license, that's all. And we have got that license. Now with the same license, we can do so many academic activities as well as the meetings. So I propose to have EC meetings on digital platforms so that both unnecessary travel time of our attendees as well as money for the IOA can be saved. I also propose to have a financial committee to help the treasurer, because there is a lot of transaction happens. Everything should be transparent and nobody should point a finger to our treasurer. So I want to have a committee to give a check or put a break on the expenditure of IOA also. We plan to have just working lunch during IOACON. With your support, it can be a great success, because I know so many people have tried in the past, but never it was accepted by the organizing secretary. I have already told this to next IOACON organizing secretary, Dr. Ram Chedda, to try working IOACON from 8 to 2 in the morning only. At 2 o'clock with lunch, it will finish, so that evening you are free to move around and do whatever the activity you can want to do. Let's hope that we'll see the light of the day in this coming conference. Friends, I cannot spell success without you. I request you to support this. Monies can be saved. Money saved can be utilized for training a program of fellowships of our younger generations. So let's have this austerity drive. This is not new, I am talking. These number 6 and number 7 points are the same. What my vision was there 3 years back. I have not changed even a single word from them. These are all my long-term visions, which I have been thinking over and I have been talking. Friends, ask what you can do for IOA rather than what IOA can do for me. I know only about 30 to 35% of orthopedic surgeons in India are IOA members. There is a large number of people are still can be made members, and our membership from 15,000 will reach in no time 30 to 40,000 if everyone becomes IOA members. Even small step will go a long way. After all, vast expanse of water in the ocean is always formed by drops and drops coming together. Friends, charity begins at home. When I'm asking you for austerity drive and curtail expenditure, I will tell for the first time I'm announcing. In the last 2 years, I have traveled to IOA office not less than 20 times. I had to conduct the election last year. I went to IOA office, came back. I have not even charged 1 paise to IOA so far. I have paid from my pocket all this time. I always make sure that I combine some conference with IOA visit so that even it will not pinch me as far as possible. Few occasions I had to pay from my pocket. But when somebody calls for conference, I used to include Delhi visit in my itinerary That's how I have not even claimed. If Ramesh Pandey would have been there, he would have said, agreed with me today. Not even charge 1 paisa. You all know I updated the web data of all the IOA members. I don't know how much I have spent, but I hosted a website. Person worked continuously for 3 months to update all the data. The bill I have not given to IOA. Why I am telling is, if I don't give the bill to IOA, somebody should not think that there is something ulterior intention behind me, what has happened in the recent election. The election officer paid from his pocket because he didn't want to IOA know who are the election vendors. But that has been taken in the court of law against him, saying that why he had to spend from his pocket. Friends, we love IOA. I've come here to sit as a president. Yes, it's a hard work of 20 years or 25 years. It's not overnight I'm coming and sitting here. I have a dream, but I have to spend some little also. It's not that I have to come only to enjoy the benefits. I have to give. That's the reason why I say charity begins at home. I request all my executive committee members to help me in curtailing the expenditure of IOA by having meetings on the Zoom. The next one is IOA Social Security Scheme and group insurance. Already I am in contact with few insurance agents. They are ready to give large percentage of benefit to us. What a normal cost about 20,000, they're ready to give it around 5,000 if there are minimum 1,000 members. Unfortunately, Dr. Rajgopalan tried about 5 years back. He was unable to succeed even to get 50 members. So again, let it be a futile one, but I want to try this for the benefit of our members. There should be a white paper on undergraduate and postgraduate curriculum in orthopedic surgery. Friends, how many days in MBBS level orthopedic is a part of general surgery? Nobody gives credit. But orthopedic surgery is the commonest problem. Accident happens day in and day out. Orthopedic surgery should be learned at the MBBS level properly. First aid should be, how to give a first aid should be learned properly. So this is also one of my area of working to have a white paper on the curriculum of postgraduates and undergraduates. As you all know, postgraduates from different colleges have different level of knowledge because of the way of their teaching. The last one is to have conference committee to allot dates so that various national level CMAs and conferences will not clash. South India, Oasis have done a beautiful work. First week is Pondicherry, second week is Tamil Nadu, third week is Karnataka, fourth week is Telangana, fifth week is Andhra Pradesh. So seventh week is Kerala. Like that, they have given this. So it becomes easy for the IOA president to accept if they fall in the proper calendar. But unfortunately, some of the major states like Gujarat, Tamil Nadu, and West Bengal, they clash on the same dates every year. So if anybody follows the protocol of the IOA calendar, the president of IOA will give preference to attend that conference first instead of attending some other conference. The grievance cell committee should give time-bound results. So that's another thing. Justice delayed is justice denied. So we should use the digital platform more effectively so that we will discuss the matter quickly. Friends, I must congratulate my predecessor, Dr. R.C. Meena. Yes, he has gone through one of the worst patch. Nobody expected in the world that there will be a pandemic in this year. Probably he will go down the history of Indian Orthopaedic Association as a president in spite of all odds. In spite of all odds, even at some point of time, I was against having a conference. What Professor Yadav says is correct. Once we decided with Dr. Yadav that we are going to have conference, I got everything streamlined. I got it ratified by the EC as well as GBM. Now nobody can question whether this conference is official or unofficial, constitutional or unconstitutional. Thank you, Professor Yadav and Dr. Kanabar. You are the main supporters for me for this, and I thank you for your guidance. Because of these two gentlemen sitting here, I could take this challenge and say to so many people that yes, we are going to have this, whatever you say, you call it as unconstitutional, yes, fine, but we are going to have a mini IOACON. But you have seen, it's not just mini IOACON, it's a regular IOACON. Just the number of people sitting in the hall is slightly less, but what is there? We are having more than 3,000 people attending online, and they're all listening to me now. I don't think if it was only a physical conference, so many people would have been listening to me. Whatever I'm talking is being recorded and it is available anytime for anybody to see now. I request all of you to give a standing ovation to my friend, my elder brother, Dr. Meena. Thank you very much. Friends,
Thank you very much, sir.
I cannot say enough thanks to all my senior past presidents who helped me in the time of trouble, especially Dr. Shantaram Shetty, Dr. Lad, Dr. Rajshekaran, Dr. Taneja sir, so, and Dr. S.C. Goel sir. Of course, I have already told Dr. Yadav and Dr. Kanabar sir. With these few words, I like all of you to follow this theme and work, because I know there are many professors in the hall, there are many senior doctors in the hall. Please, please implement Atmanirbhar Orthopaedics, Indian at heart, global in competence. Thank you very much.
Wonderful speech, marvelous vision, kind words to everybody. This is quintessential Dr. Shiv Shankar for you. Always nice, always humble, always looking forward, and hardly have ever here said a single word which would be unlikable to any soul. So there's just a bit digression. I would inform the house, all the beautiful ladies and dashing gentlemen, that incumbent first lady of Indian orthopedics, Mrs. Preetam Meena, had just arrived. So I want, this was the lady behind all his crusades, all his battles, as Dr. Daima put, Dr. Rana's battle and Sanga's battle and all other Haldi Ghatis. Even History Channel has emphatically declared that Rajput warriors were better than Yakuza, Mafia, Irish Republican Army, and everywhere. So, anecdote of Ranas and Sangas is not local, it is global. As Dr. Shiv Shankar told us that Indian at heart and global in competence. So this Rajasthani warrior was emphatically supported by this lady, lean and thin in stature, but head and shoulder high to her peer and contemporary. Thank you, Babiji. And she's so humble that her husband is arranging food for 1,500 or 500, but she will not throw her weight around. She will request me to arrange one coupon if I can. Otherwise, just get some food for his son who has not arrived. I haven't seen a more benign lady in my life, besides my parents, that I would say. And then for all other lady in the house, although we have given a standing ovation, I just want to salute them. So beautiful ladies, my heart always skip a beat. They are all graciousness personified, a spring of youth, a fragrance of youth. Our coming first lady of IOA, Dr. Lalita Shivashankar, graciousness personified and fragrance of youth as well. Graciousness meet fragrance and beauty. That is Mrs. Lalita Shivashankar.
Great lady of this house. सारका कहाँ पे? अरे आराधना जी प्लीज आप उधर कहाँ बैठा दिया हमारी सारका जी को इधर भेजो ना आप.
All four could have been sit together, but probably
सारका आओ ना.
the beauty has to be distributed. Probably this is what their plan. So they just occupied four corners. Could be their idea. We never know what goes in the mind of this beautiful lady. All the time we cannot figure it out. But then after this photograph, I'll move to the next. So Gentlemen, give them round of applause. Then hence we move to our next session, that is accepting and acknowledging our academicians, people who contributed. There has been a token of appreciation to Dr. S.S. Mohanty. He has not arrived. Then I would request Dr. Ajit Shinde to please come on stage. The committee want to give them a token of appreciation. Please. He's coming. And we will have Dr. N.J. Karne is no longer here. Probably he's left. So we will have to collect his certificate as well. Kiranda, is he here? Kiranda? I would request our outgoing Secretary General, Dr. Atul Srivastava sir, to hand over the charge to our newly elected Secretary, Dr. Naveen C. Thakkar.
Best services to the IOA. And Mr. President will make it success, Atmanirbhar Orthopaedics in a team. And we'll need suggestion from all the members of the IOA. Thank you.
Thanks for your words and inclusivity, sir. A wonderful team in the present past term, and a wonderful team will occupy the house. And then I will go ahead with the token of appreciation distribution. May I have Dr. Shakir Jati? He left. So next is Dr. Rajiv Raman has left. Dr. Abhimanyu. Dr. Abhimanyu, he was the backbone among the organizers. We also had a token of appreciation for Dr. Amulya Kumar Singh, Dr. Bhuvan Kumar Singh, Dr. Sudhir Kumar. Is the next horse in the pipeline or in the stable of Dr. R.C. Meena. He has got an uncanny ability to find people who will do better than their original capacity. Then I would invite Dr. Devyanshu Goyal to please do come on stage. Devyanshu Goyal. And collect his token of appreciation. He did a lot of back-end work, lot of backroom loose ends he cleared, and few people have left. Then I would invite Mr. Vijay Purohit to come on stage. Mr. Vijay Purohit. He has gone. From ICS Global, the organizers, the event team, ICS Global. Do we have Piyush Jha? ICS Global, anybody? Yes, Piyush Jha, please do come on stage. In these difficult times, you did a marvelous job, wonderful job. And Vijay has also arrived. Then, Mr. Vijay Purohit, if you are free from your work, which never ends, and both, yeah. Vijay has been diagnosed with how many elements? Corona has taken its toll. He has put his health, his peace online. Nagpal and Sons, Team Nagpal, please come on stage to collect your token of appreciation. Then Grover and Sons, Team Grover, I mean to say. Susilo Pathak, anybody, please do come. And when we go ahead, we cannot forget, we shouldn't forget the immense contribution from our other colleague. There are so many sitting in our house. I tell them in these moments we do tend to forget, but I shouldn't forget Dr. Amit, Dr. Jakir, Dr. Ravin Lamoria, Dr. Pankaj Jain, and all my Dr. Rajkumar Harswal. These are the people who are doing the back end work and doing these day-to-day work so we can execute these things. In these high moments, shouldn't forget them. Our residents, all the people, they were there working day in, day out. Then I will invite industry colleague, Troika Pharmaceutical. for collecting their token of appreciation. Troika team, Team IPCA, Tynor, Allenger people, they were there. Allenger, Team Allenger. Could you come please on stage? Yeah. From Team IPCA, Jole Singh Nirmalia and his team has come. Team Troika. Please, आप आ जाइए on his work. Team Troika. Tynor Surgical. We cannot forget our sponsors who, without any social gathering, anything, they still agreed to. Next is Tynor Surgical, Pankaj and team, and he sang a wonderful song was last night. Good work, Pankaj. And then other people who supported, I would just and take their name: MacLeod, Alkem, Striker, Aristo, Jaidas, I'm Oxporte, Matrix, Omnicoris, Aristo. These were all our supporters, and we shouldn't forget all our colleagues, our residents. They worked, Siddharth and other people, Karthik at AVs, everybody. Organization team has decided in lieu with IOA to give a citation to Dr. Amar Singh Ranawat that will send to USA for joining and supporting us.
So friend, in the end, and in the last but not least, as an organizing chairman and president of IO 2020, and now within a minutes, just immediate past president, I say that this conference has been attended by physically registered 670 pupils, on the digital platform by the 16,000 pupils, and displayed across the country and world as well. And many congratulations and well wishes and appreciations messages and mails are coming regularly on my account from the country and abroad. And the last, I would like to say, friends, again few words that बड़े-बड़े शहरों में और बड़े-बड़े फंक्शनों में छोटी-छोटी बातें और छोटी-छोटी गलतियां होती रहती हैं। उम्मीद करता हूं आप लोग उनको नजरअंदाज करते हुए, अगर कहीं रह गई हो तो हमें माफ करेंगे। मेरी तमाम टीम, ऑर्गेनाइजिंग टीम, माय डिपार्टमेंट, डॉक्टर दायमा, डॉक्टर बंसीवाल, डॉक्टर पंकज, डॉक्टर अनुराग, डॉक्टर रविंद्र, RP, and Umesh, thanks to all and my all residents. And now I declare the end of this IOG annual scientific meeting, 65th annual conference of Indian Orthopaedic Association. And I invite you, all of you, for the coming 66th annual scientific meeting of Indian Orthopaedic Association, IOACON, Mumbai, will be held in the last month of 2021. Thank you very much, friend. I would like to give the award of excellence to the Arun, who did a lot of work day and night and a very busy schedule. Thank you. आप award और letter घर पर अभी तो शायद इधर होगा. Thank you very much. Thank you very much.
Sir,
yes, sir.
I request Dr. Ajit Shinde to come and invite.
Yes, sir. Ajit, sir. Sorry. Yes, sir. Ajit, sir.
Of
Please.
IOACON 2021.
Or if
Mumbai.
anybody want to say something, so please, in the last moment. Sir, Ajit, sir.
Dignitaries on of the dais, and my dear friends. First of all, I congratulate newly elected president, my friend Shiv Shankar and Dr. Thakkar. At the same time, I congratulate outgoing president Dr. Meena and Dr. Srivastav for their excellent work and this wonderful arrangement of the conference. Now it has become a challenge to me. If a person can arrange a conference in 2-3 months, I cannot say like that, ki I have given the task of IOA 2021 in the month of April and how I should arrange in the month of December. I am sure with me, I am fortunate. Central Committee President also is from Maharashtra. And I assure all of you, the Mumbai IOCON is going to happen. Either 100% physical. You don't worry. And now these people have shown partly physical and partly online. But we are going to do online conference at Geo Convention Center, and it will be the wonderful event. Academic as well as entertainment, everything. And I request all of you to come to this conference with all your families and friends. Just now Yadav sir has given me 666. It is a conference of 6-6. So at least I have to hit to 6. Otherwise you people will not appreciate my work. With these words, I thank you all of you. There are 2 persons. One Pradeep Kumar and second Treasurer Sandeep Kumar. I will need their help off and on as the organizing chairman of this conference. So be kind to me.
Always there for you, sir.
And also I congratulate this young man who has made this show wonderful. Thank you. Thank you very much.
Everything, a good thing has to end. So that this is what Dr. Meena has already announced. And now this is the news from the center that our awesome valedictory function and awesome conference is over. And we will all rose up for national anthem after this photograph session. Team Grover. Pathak. Thank you, everybody. And I must not forget to thank my family as well. 4 or 5 women in my life. My grandmother, Sushita Devi, my mother, Bhagwan Devi, my better half, my daughter, my brother's daughter, my niece, everybody. And thanks all the people, including Professor S.S. Yadav. Without him, and but that is the reality. That is the reality. Thanks everybody. If I forget, Dr. Anurag, Dhakar, Dr. Pankaj, if I forget, then just you.
Okay, hello.
Yeah, you take from this end. Madhum. పోదండి సార్
Hello. Good afternoon, everyone. How many speakers are there? Fine. We'll start. I think Dr. Rahul, you can start. Dr. Rahul is not there. Next is Dr. Avinash. Please. We'll be perfectly on time, right? I'll welcome Dr. Rajkumar.
Good morning, sir. My topic for today is giant cell tumor at the head of thallus, which is a rare entity. So giant cell tumor, also known as osteoclastoma, is a benign locally aggressive tumor with a tendency to recur. It accounts for approximately 4 to 5% of primary bone tumors typically occurring in the epiphysis of long bones. GCT of the thallus is a rare entity and it occurs more commonly in the third decade of life. So our patient was a 36-year-old female presented with complaints of pain in the right ankle and foot with difficulty in walking for 4 months. Pain was insidious in onset, dull aching in nature, gradually progressing and increased on weight bearing. She had a trivial injury to the right foot 4 months back. X-ray was taken and was normal and was treated elsewhere as chronic deltoid ligament tear. Pain was significantly increased after that. So examination of the patient revealed that there was a mild swelling in the tarsal level in the dorsal aspect, tenderness over the medial aspect of the thallus. So range of movements, ankle and subtalar joints were normal. X-ray taken on the patient presented showed a light lesion in the head of thallus, so MRI was suggested. Hemogram showed ESR mildly elevated. MRI suggested aneurysmal bone cyst in the head of thallus with fracture of anterior cortex. So here you can see the T1 weighted images of the MRI, T2 weighted. Chest radiographs were obtained just in case to rule out any pulmonary metastasis, and patient was advised for surgery. So this is a Campanacci grading for the tumor, and it's given to 3 grades, where grade 1 comes under a well-defined, well-marginated border with the surrounding rim of mature bone, with the cortex being intact. Grade 2, extensive cortical thinning with the integrity is preserved. Grade 3, where there is no borders defined, and extension into the surroundings of tissue. Campanacci 1 and 2 can be treated with curettage and with adjuvant therapies. And grade 3, while it is treated with a wide excision. So this was the intro of pictures. Through an anteromedial incision, thalar head was exposed and the lesion was reached from the superior roof. Reddish brown tumor material were curated out. As anterior articulating surface was more intact, more than 90% of tumor walls were curated out with a high velocity burr. And then ipsilateral iliac crest corticocancellous bone graft was used to fill up the gap. Was the post-op intra-op picture of the C-arm showing a well-defined and the post-op specimen showed that it is probably a giant cell tumor of a grade 1 right thallus. So in the post-op period, we followed up the patient. The post-op period below knee slab was applied for 12 days, and following which suture removal was done, and below knee cast was applied for 6 weeks. Active and passive ankle movements were encouraged later. Partial weight bearing started initially and followed by full range of motion. So the patient was being followed up for every month, and the patient is now in a 7th month of follow-up. So recent X-ray shows a good consolidation of bone graft and had no collapse of articular margins, and there were no clinical or radiological evidence of recurrence. We evaluated her thoroughly with CT of the lungs and everything. So discussion. The thallus is an unusual site for GCT. Prior for deciding the treatment, certain anatomical and biomechanical factors needs to be considered with regard to extent of resection and methods of reconstruction. The treatment of GCT is directed towards local control without sacrificing joint function. Although marginal or wide resection, a wide excision of the involved bone is curative if contamination is avoided, it is associated with recurrence. In order to counter this problem, intralesional extended curettage, either by physical or chemical means, is followed. The methods for reconstruction of the defect after curettage include bone graft and morselized bone graft. Whether to use bone graft or bone cement is still a topic of debate, but both have their advantages and drawbacks. The treatment of DCT is directed towards local control without sacrificing joint function. Although marginal or wide excision of the involved bone is curative. Sorry. The method of reconstruction of the defect after curettage include bone cement advantages. Cytotoxic hyperthermia kills tumor cells. Radiographic detection of recurrence is easier. Immediate structural support and rapid early weight bearing can be done. The drawbacks, however, are long-term degeneration of articular cartilage in subchondral lesions. In weight bearing areas, it is relatively weak when subjected to shear and torsional forces. Bone graft, the advantages are remodeling occurs after along stress lines. Once incorporated, reconstruction is permanent. The drawbacks, however, are recurrence relatively difficult to spot. Autograft quantity is limited and donor site morbidity is there. Additional stability of articular surface by T-construct method of grafting has also been done and proven to be effective in remodeling. Conclusion, intralesional extended curettage with burr and bone grafting is a successful and effective method to treat benign giant cell tumor of thallus. In this case, at a 7-month follow-up, there was a good incorporation of the graft and preservation of the articular surface and no signs of collapse. Thank you.
Thank you, Avinash. Nice one. But you have not shown post-op X-rays.
Unfortunately, it was not recoverable.
And pre-op also. We don't have pre-op
You have
X-rays.
only pre-op MRI you have shown.
Yes,
sir.
No X-rays.
No X-rays. I couldn't get
Bone tumors, the gold standard are the X-rays, right? So if you miss them, then it's not worth it.
I understand.
And Avinash, second, what's your opinion about regarding biopsy taken prior to the surgery?
taken prior to surgery.
Did you took, I think you didn't take biopsy.
No, we didn't take, sir.
But the
We just
MRI,
took it on the
MRI
table, sir.
report was saying it is a aneurysmal bone cyst,
Yes, sir.
and yeah, then you plan the curettage for
Planned
that.
the curettage.
But there's difference between the extended curettage and curettage for ABC. So it was in your mind whether you are going to do an GCT curettage or an ABC only.
We were not planning for any extended curettage, sir.
Okay, so it was decided on the table.
Yes,
By seeing the.
But on the table and after the follow-up, we were curiously noting around down for any recurrence of the lesions, sir. So we were actually relying more on the follow-up of the patients.
How did you get how did you decide whether you need extended curettage or simple?
So we did
curettage?
it on a prophylactic basis, sir.
Okay, for the all benign tumors, you do like that?
No, sir. We just tried for this case, sir, since it was a small
Okay.
lesion.
But the message is clear.
The
Whether you are
management of ABC and GCT are very different. Nowadays, you don't prefer to do a curettage for ABC unless until it is recurred. So possibly you have taken the patient for surgery.
We just had it in mind, sir. So in case if it turns out to be GCT, it will be at least helpful
No,
for
once you have done a curettage for GCT and recurrence occurs, then possibly then you have no other option to
do
either
a
for-
wide.
yeah, you cannot salvage that foot. It becomes a big mistake. So the message is go for a biopsy first. Unless until you are very sure or you have a typical location. GCT talus is uncommon. And without biopsy, it's not the right way to move on, right? Thanks. Good presentation. There's one more question.
If you're thinking that this was grade 1 GCT,
Yes, sir.
then rather than going for bone grafting and lesion, better would have been you should have used cement. Because if you are managing ABC, then bone graft is good. But if you are considering GCT, even grade 1, then curettage and cementing should, that is the standard treatment
better
rather than bone grafting, because you cannot identify or early detection of any recurrence or something is there. And second thing, what sir said is absolutely right. Better to go with biopsy first with treatment rather than initial complete treatment.
Second, now Dr. N. Prabhakaran. Please come.
Good
We
afternoon.
want you to finish within 8 minutes and we'll leave 2 minutes for discussion, right? Start.
Good afternoon, everyone. My topic is on a rare case report of cerebrotendinous xanthomatosis presenting with a bilateral Achilles tendon xanthomos. Introduction. Cerebrotendinous xanthomatosis is a rare autosomal recessive and hereditary progressive storage disease characterized by marked increase in plasma and brain cholesterol levels. The incidence of the disease is 1 in million individuals, so it's very rare disease. Clinical symptoms usually dominated by the clinical features of the disease, such as cataract, tendon xanthomos, and progressive neurological dysfunction. So the early diagnosis is extremely important as patients benefit from therapy with quinodeoxycholic acid, and further progression of the disease can be prevented. So I hereby report the ultrasound, CT, and MRI findings in a 24-year-old female who presented to us with the typical features of this disease. Case report: a 24-year-old female patient presented with bilateral ankle swelling on the posterior aspect since 6 years, which was gradually increasing in size for the past 2 years and associated with pain for past 2 years. And there is a history of difficulty in walking, history of severe attacks of diarrhea in childhood, past history of bilateral cataracts was there, which was operated, history of seizures present, her birth history was normal, but patient had history of mental retardation with a history of delayed milestones. Her parents recognized that she had a mental insufficiency, poor attention and concentration with impaired memory, and by the time passed, these findings became more evident. On examination, physical examination showed a nodular fusiform swelling on the posterior aspect of bilateral ankle just above the calcaneal tuberosity, about 8 cross 7 centimeter on the right side and 7 cross 6 centimeter on the left side. Swelling was mildly tender on both sides with irregularity noted. It is not adherent to the underlying bone and it is mobile. Neurological examination showed mild spasticity in lower extremities and power was normal. She had cerebellar signs with intentional tremors and nystagmus. This is a pre-op picture showing a fusiform swelling on the posterior aspect of bilateral ankle. Investigations, we proceeded with a blood investigation where a complete hemogram was normal and serum LDL cholesterol and triglyceride levels are also normal. And there is elevated plasma cholesterol and total cholesterol level in the serum, and serum proteins are normal. Coming to the X-rays, on plain radiograph of ankle lateral view bilaterally, it revealed a bilateral soft tissue opacity in the posterior aspect of distal third of bilateral leg, extending superior from the calcaneum, and there is no calcifications noted. And we proceeded with ultrasound, where there is a loss of normal fibrillary architecture of both Achilles tendons, with thickening and smooth symmetric hypoechoic infiltration were noted. Where ultrasound, abdominal ultrasound and thorax CT were normal, where EEG and NCS studies were normal. And MRI of bilateral Achilles tendon showed diffuse enlargement of the tendon from musculotendinous junction to the calcaneal insertion, and also showed heterogeneous hyperintensity signal on the T1 and T2 images. This is an MRI picture showing a diffuse involvement of a tendon from the insertion till the musculotendinous junction. And her MRI brain, since brain is also involved in this such disease, showed periventricular and subcortical hyperintensities. You can see the hyperintensities around the ventricles here. And we proceeded with the FNAC, where a smear showed sparsely cellular and predominantly foamy histiocytes in clusters, few mesenchymal cells, and occasional inflammatory cells. With these physical, radiological, and biochemical findings, we diagnosed the patient as cerebrotendinous xanthomatosis involving bilateral Achilles tendon. So initially, actually, cerebrotendinous xanthomatosis is a medically treated disease. So we started with chenodeoxycholic acid and tablet atorvastatin for 1 month duration. Still, patient has no regression of symptoms and range of movements are still restricted. So we proceeded with a subtotal excision of xanthoma of right foot initially, and tendoachilles reinforcement was done. And limb was maintained in POP cast with ankle in plantar flexion for 4 weeks. After that, the same procedure was repeated in the left side Achilles tendon. And after 1 month, we started partial weight bearing. And we also continued statins and chenodeoxycholic acid post-operatively also. This is an intra picture showing diffuse swelling where we excise the xanthoma with remains of Achilles tendon, and we have repaired it. This is the specimen, and we send the specimen for the histopathological report, where wide areas of collection of foam cells with cholesterol crystals with giant cell reaction with bands of collagenous and fibroadipose tissue has come. This is diagnostic of bilateral tendoachilles xanthoma. This is the immediate post-op picture where wound is healthy on both sides. And after 6 months follow-up, patient can improve range of movements where dorsiflexion is about 0 to 10 degrees and plantar flexion 0 to 20 degree. And we continued both chenodeoxycholic acid and statins post-operatively. Her cardiac status were normal, and she has improved symptoms clinically, and there is good range of movements also. This is a post-op range of movements where she can do dorsiflexion about 0 to 10 degree. Discussion, cerebrotendinous xanthomatosis is a very rare autosomal recessive lipid storage disease with prominent neurological features associated with multiple tendon xanthomas, dementia, cataract, progressive cerebral ataxia, spinal cord paralysis, peripheral neuropathy, and chronic diarrhea. There is accumulation of cholesterol in many tissues, particularly in the brain and tendons. And in this disease, bile acid production is markedly reduced, which leads to reduced chenodeoxycholic acid concentration in the bile. However, specifically cholesterol accumulation produces functional abnormalities is unknown and should be investigated further. Untreated, if the disease is untreated, is associated with high mortality and morbidity from coronary artery disease. So it is important for an orthopedician to be familiar with this disease, because if it is diagnosed earlier, we can prevent the premature coronary atherosclerosis so that we can save the patient. And there are differential diagnoses where.
Please end now.
Sir.
Finish.
And treatment part, I'll just finish it, sir.
Sure.
Actually, although it is a medical treatment, there are indications for surgical excision of xanthoma where there is inflammation of the tendon, or if there is chronic symptoms like pain or difficulty in walking. And we went for subtotal resection because the involvement of xanthoma is local, and we can go for total excision with reconstruction also, but it's always better to preserve the original tendon here. So my conclusion is nodular or subtotal excision combined with postoperative statin and chenodeoxycholic acid therapy appears to be a good treatment option for painful localized Achilles tendon xanthomas and can preserve patient's own tendon as well as decreasing the risk of recurrence. Any treating orthopedic surgeon has to be familiar with this disease because it's a rare disease. usually we'll focus on the local xanthoma and we'll treat only the xanthoma part, and we can neglect the patient because this disease has a high mortality rate with coronary artery disease and myocardial infarction. So it is best to diagnose the disease earlier, and we should concurrently follow with the medical treatment also. Thank you, sir.
Any questions on the floor? How much is your follow?
So actually, this is a very rare case, sir. Only one case we have.
Follow-up of this particular
Follow.
case?
This is a 6 months follow-up, sir.
And there is no recurrence?
No recurrence, sir, till now.
Satish,
And there are evidence that subtotal excision with, if we continue chenodeoxycholic acid and statins post-operatively, there is evidence of no recurrence. That might be a emerging option for this xanthoma, sir.
Any other study which has supported this? Because
Yes.
there are some reports which do exercise and do a reconstruction.
Yes, sir. There are some reports where they will do reconstruction or tendon grafting from tensor fascia lata or else from flexor hallucis longus also. And there are cadaver tendon grafting techniques also. But this is a biological repair where we won't disturb other soft tissues. And there is a good follow-up report also, sir, because we are giving post-op medical treatment also, so that it will prevent the further deposition of fatty globules in the any tendons or in brain also, or in blood vessels. So it is a generalized preventive measure.
Satish, good presentation, quite a rare tumor. Definitely, it will increase our knowledge in our
Yes, sir. Thank
anatomy also. But I would like to emphasize one point.
Yes, sir.
Always try to take the biopsy first.
Yes,
FNAC
okay.
is not helpful in many
Sure, sir.
settings. Take biopsy, take proper histopathological diagnosis, then forward it. Because
Sure.
sometimes you may end up with some tumor.
Yes, sir. GCT tendon.
GCT or maybe soft
may
tissue sarcoma,
encounter,
maybe.
yeah. But the typical general features of patient suggestive towards this rare disease.
But still the biopsy is gold
Yeah,
standard.
sure, sir.
Thank you.
Thank you so much.
Now, Dr. Satish. We'll prefer that you limit your time to 8 minutes, right? Has to be fast.
Yeah, good afternoon. I'm here to discuss about our prospective comparative study comparing the PRP versus corticosteroids for recalcitrant plantar fasciitis. Plantar fasciitis per se is one of the most commonest cause of heel pain, and it can be very challenging for clinicians to treat it successfully in the long run. And it typically affects mostly men and women of age group of 40 to 70 years, and 10% of the general population is always affected bilaterally in 3%. The pathophysiology is not exactly known whether it is due to degeneration or inflammation, but there are ideas of both the schools. Treatment options include stretching exercises, heel cups, night splints, weight loss exercises, and NSAIDs. Steroids versus PRP. Steroids provide excellent short-term results, but steroid treatment is associated with own complications like rupture of plantar fascia, heel fat atrophy, and nerve injuries and infection and muscle injuries. Due to the recent advances in the regenerative medicine, autologous PRP has become one of a commonly used treatment modality and most commonly used orthobiologic agent to treat these musculoskeletal disorders. Hence, we aim to compare the efficacy and safety of using PRP over a steroid for plantar fasciitis. It is a prospective single-blinded study done over a period of 1 year in Rajiv Gandhi Government General Hospital. We included cases of plantar fasciitis who were refractory to the conservative line of management and excluded patients who received a recent shot of steroid or who were already on NSAIDs and with foot deformities or previous surgeries. And the patients in the steroid group received 1 ml of triamcinolone injection at the point of maximum tenderness near the medial calcaneal tubercle. And in case of PRP group, using a 20 ml of their venous blood, PRP was prepared by a double spin method and injected at the point of maximum tenderness. We followed the patients using AOFA score and VAS score for pain at sequential intervals of 3 months, 6 months, and 1 year. We had an average follow-up of 1 year for all the cases. And we chose 25 patients in both the arm with the mean age of around 40. And these are the male-female ratios. These are the preoperative scores which were comparable for both the groups. If you look into the results of AOFA score and VAS scores, there is significant difference noted at PRP group at 1 year period. You can see it in the graph that they have a comparatively significant improvement in both the PRP group and steroid, but the difference is significant at 1 year in the PRP group. And also in the VAS score, it is significantly decreasing to that of the preoperative period, but the VAS score didn't show any significant difference between the two arms, whereas in case of the functional score, we noted a difference. So plantar fasciitis means the inflammation of the plantar fascia, right, at the site of attachment. But the recent studies indicate that it's a condition of degeneration rather than a true inflammation alone. However, true inflammation is also seen in acute cases, whereas in chronic stages where these are recalcitrant cases undergo a lot of degeneration. So modalities like PRP has a role in their management because autologous PRP for these chronic plantar fasciitis is a treatment modality for the past decade with various growth factors like TGF beta, VEGF, PDGF, FGF, and EGF. They possess both the anti-inflammatory, antibacterial, and regenerative capacity. Hence, the presence of various growth factors along with the pro-inflammatory cytokines in the PRP will initiate a healing process in this regenerative process. And hence, once PRP is activated, the injected site will undergo a regeneration and anti-inflammatory property will enhance the uh, regeneration of the injured and inflamed fascia. This study has some limitations like only a small population is involved in either of the arms and it's a single center study. A large randomized controlled trial of this similar sort with double blinding or even a triple blinding would be even more concrete to say this evidence. There are even a meta-analysis of this similar nature which is saying that there is limitation of high quality evidence to say whether PRP is superior or not. This is done in 2015, whereas this 2020 meta-analysis shows that in patients with chronic plantar fasciitis, the current clinical evidences suggest that PRP may lead or even have a greater improvement in pain and functional outcome, whereas in our study, we found improvement only in the functional outcome rather than in the pain arm. And to conclude, I say that both PRP and steroid injections significantly reduce the pain at 1 year. However, functional improvement were significantly better in the PRP arm compared to that of the steroids. And PRP injection therapy remains more effective compared to steroid injections in the management of these recalcitrant plantar fasciitis, considering the degenerative component of the disease entirety. Thank you.
Thank you. Good one. Can you say what functional improvement you have observed in your patients?
Yeah, we observe the range of movements, sir, and their stretching ability and stride length,
Range of motion of ankle joint.
ankle, and the stretching ability of the plantar fascia.
Okay. Any other activity?
Walking.
Because most of the walking, how long? Well, is it not associated with pain?
Yeah, vascular we are
Because
seeing
it-
for pain, sir.
You said pain has improved.
Yeah, pain is improved. They are able to walk free without pain, and early morning pain is also reduced.
Satish, did you try conservative treatment first or
Yes,
directly
sir.
or
All are recalcitrant cases, sir. They
All are
failed the
recalcitrant.
primary line of management.
Okay.
They were not responding much to NSAIDs or stretching therapy or any heart fomentation or anything.
both groups?
Yeah, both the groups.
How you assess the range of motion in patient? If you want to compare whether our side treatment is working or not,
Uh-huh.
so how should we assess range of motion of your LE that we do functionally? How we are going to ask patient to show what is the range of motion before treatment and after?
Whether he is able to stand on his heel or on the toes. Okay, thank you.
Next speaker is Sheikh Mohammed. In plantar fasciitis, even 8 or 9 types of, every type of injection has been used. Steroids, saline, hypertonic salines, and almost everything has given a good result for 6 months. And after 1 year, almost everybody has shown almost the same results. So till now, no preferred treatment. And we prefer to do this with sono-guided, ultrasound-guided injections. We don't prefer to give direct injections there, right? Yeah, now, thanks.
Good morning, sir. Good morning, Chairperson. Good morning, delegates. A descriptive study of post-operative infection in open orthopedic injuries. Introduction: exposure of subcutaneous tissue in open orthopedic injuries provide favorable environment for microorganisms which are potentially pathogenic, causing higher risk of wound infection. That's why primary goal in the management of open fracture is the prevention of the infection of the bone and soft tissue. To achieve this goal, the most widely accepted treatment protocol include early surgical debridement, irrigation of open wound, administration of broad-spectrum antibiotics, and stabilization of fracture. In this study, we studied the pattern of bacterial isolates in open orthopedic injuries and their sensitivity and resistance to commonly used antibiotics in vitro. Method: the descriptive study was to be conducted on open orthopedic injuries being admitted to the orthopedic department from June 2019 to June 2020 at SMS Medical College and Hospital. Clinical and radiological outcome with wound examination for any sign of infection. Follow-up was taken at second day, fifth day, eighth day, 14th day, 14th, fourth week, sixth week, and third month. Result: according to present study results, 19% of patients had positive culture reports. Culture analysis showed gram-positive bacteria Staphylococcus aureus 52.6% as most common microorganism isolates and Klebsiella pneumoniae 10.5%, while gram-negative bacteria, namely Pseudomonas aeruginosa 26.3% and E. coli 10.5%. High drug sensitivity was observed for ciprofloxacin 31.5%, rifampicin 26.3%, and levofloxacin 21.1%. High drug resistance was observed for ciprofloxacin 26.3%, oxacillin 15.7%, penicillin 15.7%, and amikacin 15.7%. Discussion: unlike surgery in other orthopedic areas, the predicting factor for infection in a fracture patient were found to be significantly influenced by open fracture rather than the underlying disease and anatomical features of the patient. Staphylococcus aureus was the commonest organism isolated from the infected cases. Early recognition of causative agent and targeted strategy are required to reduce morbidity, eliminate infection. Introduction: the primary function of insect skin is to control microbial population that live on the skin surface and to prevent underlying tissue from becoming colonized and invaded by the potential pathogens. Exposure of subcutaneous tissue following loss of skin integrity, that is wound, provides a moist, warm, and nutritious environment that is conducive to microbial colonization and proliferation. Since wound colonization is most frequently polymicrobial, involving numerous microorganisms that are potentially pathogenic, every wound is at potential risk of becoming infected. The rate of infection associated with internal fracture fixation may be as high as 3.6 to 8.1% for closed fractures and 30% for open fractures. This high incidence of postoperative infection in fracture contrasts with the risk of less than 2% in elective joint reconstruction surgeries. The emergence of resistant strains has increased the morbidity and mortality associated with wound infections. Many factors have been considered to be predispose the development of post-surgical infection and are related to host trauma and treatment itself. Identification of these factors is crucial in planning prevention strategies. Surgical treatment of fracture occurs in an area which is already traumatized, where the need for early intervention often overrides the desire to wait for the same, necessary for complete recovery of the soft tissue and minimize comorbidities. Open or compound fracture are fractures that communicate with the outside environment through a wound. They are usually caused by high energy trauma. Infection at the site of traumatic wound is a common complication of open fractures. About 60 to 70% of contamination of open fractures occur at the time of injury. Bacteria originate both from the skin and outside environment. The dynamics of bacterial population in soft tissue wounds and bone differ greatly over time. Following bacterial infection of bony and soft tissue is a major challenge which might further lead to sepsis, acute or chronic osteomyelitis, delayed union, non-union, or even loss of the extremity. Multiple studies have revealed that the pre-debridement wound culture had minimal values in the predicting the post-debridement wound infection since infecting pathogens were commonly hospital acquired. The primary goal in the management of open fracture is the prevention of infection of the bone and soft tissue. To achieve this goal, the most widely accepted treatment protocol include early surgical debridement, irrigation of open wounds, administration of broad-spectrum antibiotics, and stabilization of the fractures. In this study, we studied the pattern of bacterial isolates in all cases of open fractures of extremities that came to our hospital. Objective of the study: the purpose of the study was to assess the proportion of postoperative infection in open orthopedic injuries, their profile of microorganism, and antibiogram. Because early recognition of causative agent and targeted therapy are required to reduce morbidity and eliminate infection. Mattel method: study design and duration. This hospital-based descriptive type of observational study design conducted on open orthopedic injuries being admitted to the orthopedic department in the teaching hospital attached to SMS Medical College, Jaipur from June 2019 to June 2020 with due permission from the institutional ethical committee and research review board and taking written informed consent from the patient. Sample size calculation: as this was a descriptive type of observational study design, sample size are deduced as 1 year cases of open orthopedic injuries admitted to the orthopedic department in the teaching hospital attached to SMS Medical College, Jaipur from June 2019 to June 2020. Inclusion criteria: open orthopedic injuries, all age groups, both sexes, fracture duration less than 1 week after hemodynamic stabilization, patient who are fit for anesthesia and surgery, patient who gave written informed consent and were willing for follow-up and participate in the study. Exclusion criteria was used so as to exclude those patients having other
Little fast, please. Only
comorbid
2
conditions,
minutes left. Only 2 minutes left now.
pregnancy, uncontrolled diabetes mellitus, hypertension, psychiatric illness, acute myocardial infarction less than 1 year, associated major visceral injuries, surgery, implantation done through already infected wound, periprosthetic fractures, methodology. So should I skip, sir, methodology and all?
Skip.
Observation studies. During the study period, 100 patients were taken for the study who fulfilled inclusion and exclusion criteria and gave written informed consent for participation in the study. The demographic data of the study population is given in table 1, 2, 3. So these are just demographic data.
You can go to the results and conclusions.
So the results start from table 9, microorganism by distribution of study. 19 patients out of 100 were infected cases. And microorganism wide distribution of the study, culture analysis showed an increase in growth of gram-negative bacteria, namely Pseudomonas aeruginosa at 26.3% and E. coli 10.5%, while gram-positive bacteria was Staphylococcus aureus 52.6% and Klebsiella pneumoniae 10.5%. So we can see E. coli were present in 2 cases out of 19, Klebsiella pneumoniae in 2 out of 19, Pseudomonas 5 out of 19, Staph 10 out of 19. Sensitivity to antibiotics wise distribution of the study, vancomycin was sensitive for 2 cases, ofloxacin for 2, cipro for 6 out of 19, levofloxacin for 4 out of 19, rifampicin 5 out of 19. And the resistance to antibiotic, amikacin was resistant for 3 out of 19, cefixime 2 out of, ciproflox 5, gentamicin 1, imipenem 1, ofloxacin 1, oxacillin 3, penicillin 3 out of 19. In this study, high drug resistance was observed for ciprofloxacin 26.3%, oxacillin 15.7%, penicillin 15.7%.
Can you go to the last slide now? It's time's up.
So discussion, management of open fracture is challenging. Infection is a major complication of open fracture. The choice of prophylactic antibiotics for open fracture was important for the management of open fracture. However, the previous studies showed controversial results of occupational therapy. One major reason was the hospital acquired pathogens were increasingly present in the infection of
Dr.
open
Sheikh, conclusion, please. Please conclude it.
Unlike surgery in other orthopedic areas, the predicting factors for infection in a fracture patient were found to be significantly influenced by the open fracture rather than the underlying disease or anatomical feature of the patient. However, only the correlation with simple open fracture has been confirmed. Therefore, further studies on the cause of open fracture and the mechanism of open fracture are necessary to determine the risk of infection. Thank you, sir.
Quite lengthy, but it was a good presentation.
Thank you, sir.
Can you summarize after your study what treatment we should offer to our compound patients to prevent?
Yes, sir. Slide, please. Open fracture are generally high energy trauma cases. So we should sometimes we need resuscitation in our emergency department. So first of all, so we should take the patient earliest possible, as soon as possible, in the OT for thorough debridement. And after debridement, we apply Gustilo Anderson and Ganga hospital scores. And then thereafter, we should decide whether it should be further managed by plastic surgery or other departments, or we should we carry out our own treatment. If it is managed by plastic surgery or by ourselves, then we should
Very
follow the
specific
patient.
answer. Very to the point answer. He's just asking how to prevent post-operative infection.
You have decided,
What?
you have right fixator, you have decided, right fixator. Now you are going to prescribe an antibiotic.
Yes, sir.
So you know what is the most common organism now.
Yes, sir.
And you also know which drugs are working here or not.
Yes, sir.
So what drug you are going to prescribe most of the time?
Sir, we should, use antibiotics which cover both. First of all, we should start with our regime with which antibiotics cover both gram-positive and gram-negative bacteria. And if there is any discharge from the wound, then we should go for culture sensitive reports and further use the exact antibiotics we.
So what empirical treatment do you use after first debridement?
Sir, after first debridement, so we use generally.
What your recommendation according to your data?
So cefuroxime.
But you did it. But you did it.
Sir, we use so cefuroxime and amikacin for.
Of this drug, definitely.
So you can only prescribe drug where you have seen the sensitivity. Most common are steroids. The most commonly used drugs are against steroids.
Ciproflox and cefuroxime. So cefixime was also used, but cefixime has poor results.
Okay,
Thank
thank
you.
you.
Thank you.
Next one, Dr. Arpit. This time we are going to stop it at our 8 minutes, right? Just too late. We actually don't require too lengthy introduction and theoretical part.
Yes,
You
definitely.
just want to stick to the study,
My
right?
topic is drug utilization pattern in orthopedics tertiary care teaching hospital of UP. So why I am doing this? Because if you can see there are two prescriptions. Okay, now you can very well understand the difference between a good prescription and a bad prescription. Both are providing treatment, but what is the difference? You can understand. So a good prescription, it's important to have better understanding to patient. Patient can review it if there is any confusion, can take alternative drugs if possible. And it's also an important medical legal document. You cannot just write it's not valid for medical legal purpose. That's not, you will face problem in court. So the present study was designed and carried out in order to check the prescribing pattern in the orthopedics OPD. The objective was to see what is the demographic profile, what are the common drugs that we are prescribing, what are the common mistakes that we are doing, what are the number of drugs we are using, and what are the most common drugs which we are using. The study was a prospective observational study. Total 261 prescriptions were used. In demographic profile, most of our patients were adult, more than 18 years of age, and approximately 1/4 were more than 60 years. The most common drug that were used in our outpatient department were basically two drugs that were anti-peptic ulcer drugs, and the second was NSAIDs. These two drugs were the most common drug used. Surprisingly, the second most common drug which we were using was an multivitamin. The third most commonly drugs that we were having that was antibiotics and analgesics. Second area of concern was polypharmacy. Now, approximately 50% of the prescriptions having drugs more than 5. So this was an area of concern which we found. What are the other mistakes that we found in the prescription pattern was the diagnosis was not written in approximately 40% of the papers. Signature of the doctors was absent or it was untraceable. The stamp of treating doctors were missing. Duration of treatment for how long he should take the medicine was not written. Follow-up advice was not clear. Now, these are the common mistakes that we are seeing in our outpatient department, probably because the workload is very high. We are catering 600, 700 patients, but still you cannot escape this, and 600, 700 patient is not the answer for all these mistakes. If this paper is going to stand in court of law, we will face problem. Because you cannot say कि 600-700 patient है sir तो लिख नहीं पाए sir follow up advice नहीं लिख पाए. Court is not going to hear all these things. So the right medicine to the right people at the right time, this is the best way, and the best way can be ensured is by adherence to the WHO recommendation of rational drug policies that we are usually not aware of. Now, what are the reasons for all this that we found? That first is lack of information. We don't have the proper information that which drug to be used upon, which are the common drugs, which we mostly rely on the data given by medical representative and the websites that we use. Second is faulty and inadequate training. Now, inadequate training, mostly we are taught good surgeries, good diagnosis, but how to write a proper prescription, nobody taught us. Even I am not taught how to write a good prescription. We just learned to seeing our professors, how they used to write, our third year used to write. But this is not the correct way. Third is poor communication between health professional and the patient. And the fourth is the patient demand. जितनी पेशेंट ने कंप्लेन बताई, यहाँ दर्द हो रहा है, ये दवाई, गैस बन रही है, ये दवाई, हड्डी कमजोर है, ये दवाई, तो हर every ill has a pill. Now that is the very common mistake that we are doing. So probably all these things we have to rectify, and we have to implement all these things in our paper, in our teaching methodology, in our training of the PGs also. So all these things are important. So I would like to conclude only. This is a short paper. Thank you so much.
Dr. Amit, you said that
Arpit.
sorry, Arpit.
Yes, sir.
You said that you always curtail 600 to 700 patients per day, but you take only 261 prescriptions.
No, sir, I'm just saying ki
Number one.
600, 700.
Second is there was selection. There was no mentioning of the doctors who were involved in these. Whether it was one consultant, two, or resident was there. What were their level of? Maybe you you put up all 261 prescription from a single surgeon or a
It was
family.
not a single surgeon. It was, there are 5 units working. So we have some paper we have taken from all the units. So it's not a biased study.
But 261 is too less if you found
Yes,
600
definitely. That
patients
is a
per day.
limitation. And even it's a single center study, that is also the limitation. It should be included in multi-center, so we can understand कि बाकी colleges में क्या चल रहा है. हमारे यहाँ तो ये चल रहा था, that I found.
सब जगह यही चल रहा है.
Any recommendations out of your study?
Sir, polypharmacy has to be reduced. We tend to write too many drugs, and the patient that we are having, that is 40-45 years, उनको already BP की दवाई चल रही होती है, blood pressure, diabetes की दवाई चल रही है, तो we have to took all this concern in mind also. Usually while writing drug, we don't think कि और क्या क्या दवाई वो खा रहा होगा, हम उसके पर्चे भी नहीं चेक करते कि और क्या क्या मेडिसिन चल रही है तुमको, what are the interaction क्या होने वाला है जो हम प्रिस्क्राइब करने जा रहे हैं उस मेडिसिन से. So we have to spend some more time to the patient ताकि हम समझ सकें कि क्या क्या वो मेडिसिन ले रहा है. And recommendation
the
is
free
we
medicine scheme is available at your center.
Yes, sir. Free medicine.
Almost all medicines are supplied free.
Sir, there are some, all medicine to kabhi nahi aa sakti. Some
Yeah.
medicines are available, but most commonly prescribed drugs are available.
And the
Definitely.
doctors are basically, they can prescribe medicine from outside also on this paper that you have shown.
Yes, sir. In UP we can prescribe. There
Yeah,
is no
this happening.
limitations.
Because as you say, another concern which you have not shown, that the availability of drugs in the hospital. Most of the times they are forced to, because I'm also working in government hospital, and they are forced to write only those medicines which are available in hospital. In that case, after, if you want to write a particular disease, you cannot write, because if indulacin is available in the hospital, you will write every patient indulacin. So when the prescription goes to the outside, you cannot justify yourself in the court of law. Why did you prescribe indulacin in a education? So there are so many concerns, and this requires representation to a state level, to a national level. So that
Sir,
we should not be forced to write medicines. We can write whatever we want, and it's the responsibility of the government to provide those medicines.
Sir, in our hospital, I can tell you, every day जब हम OPD जाते हैं, there is a list which comes out from the OPD कि these drugs are available today. Yes, sir.
Second thing is, what you say, people are not bothered about the medicine of other medicines a patient is taking. No, it's not that. You should contact, if this is happening to your hospital, it's a problem in your hospital. Because in my hospital, we are taking care of this. We always ask what are the problems you are having. I will show my presentation, and I will show how the changes of the things. So we are taking.
No, sir, I am talking about my hospital. This is the thing.
It's actually a very big topic.
Yes, sir.
And it's a lot of debate. And
It's
so
a
many things
debatable
are
topic.
happening.
It's a controversial topic also.
So
No, sir, I
basically,
am
he
not
has to raise the
dignifying.
issue.
I am raising the issue. I am
He is
raising the
just
issue, sir.
raising
I
the
am not
issue.
dignifying my institute. I am raising the issue.
Yeah, sure.
Maybe we are taking history of all the 100 drugs, but they are not coming on the paper. This may be one. Because everyone asks, "Kya kha rahe ho dawaii ka?" But that is not coming on the OPD slip. One thing,
In hospital, we are providing a book. So whenever he goes to any doctor, all medicines are written there. So normally we see, okay, medicines have
That is a good thing, sir. That is a good thing. That
No, there are again plenty of things. It's not possible to finish there. The message is well taken. Thank you.
Thank you, sir.
Dr. Arunab. ये स्लाइड पूरी नहीं आ रही है. हाँ, please. You can start. Yeah.
Good afternoon, everyone. I'll be presenting my topic on
Everybody
regenerative
silent,
therapy.
please. Yeah.
Regenerative therapy in delayed and non-union of fractures. Delayed union is described as ununited fracture that continues to show progress towards healing or has not been present long enough to satisfy an arbitrary time criterion for delayed union. The lack of precision in its definition decreases its value in reports of results. Whereas non-union is defined as a fracture that is at least 9 months old and has not shown any signs of healing for consecutive 3 months. The process of bone regeneration has been greatly enhanced by the identification of growth factors present in the platelets. The application of growth factors such as platelet-derived growth factors and transformic growth factor beta is seen as an available proposition for enhancing the rate of bone formation and the final quantity of bone formed. Platelet-rich plasma was first defined in 2007 as a preparation of platelet present in a small volume of plasma containing a large amount of growth factors, which is essential for bone growth and regeneration. The benefits involved in the application of PRP is its ease of availability, ease of isolation, good handling, and storage properties, and its application in the field of bone tissue engineering. PRP therapy typically involves an autologous blood draw and centrifugation to separate and obtain the platelet concentrate. PRP is then activated and applied to the defect site. However, it has been shown that thrombin as a clotting agent to form a platelet gel can result in rapid activation of platelets and ultimately a mass release of growth factors. These growth factors, which undergo a burst release, are cleared before they can have an stimulatory any before they can have any stimulatory effect on the cells. When platelet gels are formed using calcium chloride, growth factors release can be slowed. Calcium chloride activates and clots PRP by forming autogenous thrombin from prothrombin, leading to the eventual formation of a loose fibrin matrix that will release growth factors over 7 days. As bone regeneration is a lengthy process, there is an obvious need for effective delivery vehicles capable of the sustained release of PRP derived factors over an extended period of time to maximize their regenerative potential. PRPs, in our study, we prepared PRP by double centrifugation, in which 30 ml of venous blood was withdrawn in sodium citrate vials. First centrifugation was done at the rate of 3000 RPM for 10 minutes. Plasma and buffy coat was then separated from RBC layer into plain vials. Second centrifugation was done at 5000 RPM for 10 minutes. The top two-third portion was platelet poor plasma and the bottom one-third is platelet rich plasma. This case number 1, 43-year-old male, alleged history of road traffic accident in 2019 August, sustaining fracture mid-shaft humerus left arm with multiple injury, primarily managed non-operatively by giving him a U-slab. He received first dose of autologous PRP injection on 22nd of October 2019, then subsequent doses every 3 weeks for 3 doses. This is the intra-op picture while giving the PRP injection under CM guidance. This is the follow-up X-ray showing the callus formation in the lateral cortex. There is another X-ray showing the callus formation in the lateral as well as the anterior cortex. This case number 2, 28-year-old male sustained trauma to right femur, fracture to the distal end of the femur in March 2019. He was operated for the same in March itself, and he did not show any signs of union till 11th November 2019. So we started him on the autologous PRP injection from 4th December, and subsequently he was followed up every 3 weeks for next 3 months. These are the X-rays while giving PRP under CM guidance. This is the X-ray showing callus formation. Another patient, 26-year-old female, she sustained intercondyle fracture left humerus in July 2019, and she came for autologous PRP therapy in December 2019, and she was started on PRP dose from January 2020, and every 3 weeks for 3 doses, she was given 3 doses of PRP. This is while giving PRP injection under CM guidance. This is the follow-up X-ray of the patient. This is the follow-up X-ray of the same patient showing the union. Another patient, 58-year-old female. She sustained fracture right shaft of femur after trivial fall at home. operated in October 2019 with intramedullary needling, and received first dose of PRP injection on 5th of December 2019. This is the intraop X-ray under CAM guidance while we were giving her PRP. These are the follow-up X-rays. So another patient, 60-year-old male, fractured both bone right leg in December 2019, and he was started on PRP injection on 13th Feb 2020. We have a total of 20 case series, but due to limitation of time, I just added only 5 cases in this. These are the follow-up cases, follow-up X-ray of the patient. Although several reports have elaborated on the advantages of PRP in the field of periodontal bone and cartilage regeneration, there are still several challenges to be addressed. We have not yet been able to obtain consistent results from the insufficient preclinical and clinical data on the immunogenicity and protective effects of PRP. First, it is important to determine the molecular immune mechanisms and cells that are involved in these responses, the dynamic fate of these implanted platelets, assessment of its clinical efficiency, and factors that influence these inconsistent results. Another challenge is in obtaining a homogeneous composition of PRP, since its composition displays relatively strong intra-patient variation. Moreover, its variation is correlated with age, sex, and the patient comorbidities. Furthermore, it remains unclear about how these changes will affect stem cell behavior in vivo. Even the preparation methodology can significantly affect its composition, and there is no standard protocol in literatures to obtain PRP or PRP gels for clinical application. These incongruences
Last 1 minute, right?
These incongruences reduce the comparability and reproducibility of the various PRP studies. Limitations are no standardized protocol for PRP preparation, amount of growth factors delivered at the fracture site to be quantified, and patient-related demography and systemic diseases. Now to conclude, as the efficacy of PRP is dependent on various factors, the outcome of PRP therapy is variable and unpredictable in orthopedic patients. Therefore, it is still too soon to suggest PRP as the first-line treatment option in complicated bone injuries such as delayed and non-unions. However, combination of PRP with natural and synthetic biomaterial can enhance the effectiveness of PRP. Thank you.
Thank you. Questions, please.
When you want to give PRP to your fracture patients,
Yes, sir.
whether you want, when you are labeling any patient delayed union,
Yes, sir.
or you are waiting for wait till it is non-union,
Sir,
or
for
during the earlier process of union, say जैसे कुछ cases में fever fracture था, आपने 2 महीने में PRP शुरू किया.
Yeah, the question, I'll reframe the question. How soon or how late
Sir,
you will intervene?
Sir, because there is no specific time duration that is defined in the literature for delayed union, so we have taken the time for delayed union as 8 to 12 weeks for our patients, for our study that we have taken.
You have injected PRP within 3 months in few cases.
Sir, in few like 8 to 10 weeks, we have taken 8 to 12 weeks. We have taken the time for delayed union. In non-union, it is the specified time. Like if the fracture is not showing any union for the consecutive 6 months, and since last 3 months it has not shown any signs of union, so the non-union time is specific, but the delayed union we have taken 8 to 12 weeks, sir.
Because the few x-rays you showed, I personally feel there was some callus formation already there.
Maybe because the natural process of
Yeah.
We all know that we used to randomize nails before.
Yes, sir.
In between that process, you can put injection and healing can be accepted.
Sir, it was only to augment the union. It was only meant to augment the union. It was not a primary this thing. The PRP was not primary, but with like operative intervention were done first, and then if we found that this fracture might go into delayed union, so we augmented with PRP, and patient was counseled, and the consent was taken that if this does not unite, then the ultimate thing will be bone grafting will be done.
Actually, time period, with the time period, it's only a subjective feeling that's not uniting or going to delayed union.
Yes,
right?
sir.
So that's great. Any other question? Next speaker, please.
Thank you, sir.
Mr. Amrit. Yeah.
Good afternoon, everyone. Myself, Dr. Amrit Singh. My topic is, does leukocyte concentration have a role in outcome of PRP therapy for lateral epicondylitis, a randomized control trial? As we know, lateral epicondylitis, that is tennis elbow, it is an overuse injury involving eccentric overload at the origin of the common extensor tendons, which will lead to the tendinosis and the inflammation of the origin of the ECRB. Now, if we'll talk about the technique which we have used, the PRP, it is a less invasive technique, minimal morbidity, and the percutaneous administration of biological substance, which with osteoinductive and the osteoconductive properties, and regenerative medicine proved its way for the modern treatment options. And in the regenerative medicine, platelet-rich plasma is the next new normal for the musculoskeletal disorders. And use of the PRP by orthopedic surgeons and the regenerative orthobiologists increased in the recent years. One of these musculoskeletal disorders is the lateral epicondylitis. A controversy on the uses is use of the leukocyte-rich or the leukocyte-poor plasma PRP for the lateral epicondylitis. Leukocyte content in the PRP solution modulates the inflammation through secretion of the inflammatory cytokines and the matrix metalloproteinase, which exacerbate an inflammatory response at the site of the action. Leukocyte-rich plasma PRP elicit a catabolic, inflammatory, and the detrimental environment, while leukocyte-poor PRP elicit an anabolic effect on the tissue being injected. In acute pathologies, leukocyte-rich PRP helps in inflammatory regeneration and early angiogenesis at the injury site, whereas leukocyte-rich PRP in chronic pathologies lead to the formation of the scar tissue at the injury sites. As there is no scientific evidence available for the uses of the right type of the PRP, which is leukocyte-rich or the leukocyte-poor PRP, to treat lateral epicondylitis, we are aiming to evaluate the effect of the leukocyte concentration and the outcomes of the PRP used for the lateral epicondylitis. This study was conducted on the clinically diagnosed lateral epicondylitis patient who satisfied the inclusion criteria of the study in the Shada Hospital. This sample size was 85. Study design was prospective double-blind and randomized controlled study. Sorry. And the time duration was from the June 2019 to the December 2020, that is 18 months. Inclusion criteria of the study was age limit from 18 to 65 years, and all cases were clinically diagnosed. Exclusion criteria was a patient with the thrombocytopenia with platelet count less than 1 lakh, septicemia, local infections, consistent use of the non-steroidal anti-inflammatory drugs within 48 hours of the procedure, corticosteroid injection at the site of the treatment, and the use of the systemic corticosteroid within a month. We divided our study group into two groups. One is received those who received the leukocyte-rich PRP and those who received leukocyte-poor PRP, with 1.5 ml of the dual spin leukocyte-rich variant and 1.5 ml of the dual spin leukocyte-poor variant, respectively. PRP was infiltrated by a single physician using a aseptic technique. The clinical outcome of the patient was evaluated using the visual analog score for the pain, and the functional outcome was measured with the using myo-elbow performance score. The first measured pre-intervention, and after that 1 month, 3 months, and 6 months, and 12 months post-intervention. If we look at the preparation of the PRP, we used to withdraw the patient peripheral blood. Then after this, there will be formation of the three layers. The first is red layer, white layer, and the yellow layer. Red layer is erythrocytes, white layer buffy coat, and the yellow layer is platelet poor plasma. In the white layer, it consists of the leukocyte, inflammatory cytokines, and the high concentrator of the platelets. After that, we used to separate the platelet-rich plasma, and we use as a for the direct injection of the injured site. Here we are using 10 ml of venous blood is withdrawn from the patient in the sodium citrate tube. First centrifugation at the rate of the 3000 RPM for 5 minutes. Plasma and the buffy coat is separated from the RBC layer into the plain tube. Second centrifugation at the rate of the 5000 RPM for 5 minutes. Top 2/3 portion is 3 ml platelet for poor plasma, and the bottom 1/3 portion 2 ml platelet rich plasma. When we talk about the results, a total of the 85 patients were randomized into the leukocyte poor PRP and the leukocyte rich PRP as of 42 and 43 members respectively. We did not note any significant difference between the two groups with regards to the general characteristics such as the age and the duration of the diseases. And the patients were serially followed for the 1 month, 3 months, 6 months, and the 12 months. And we noted significant improvement in the pain and the functional outcome of the patients, and established that the concentration of the leukocyte did not play a role in altering the course of the treatment outcomes. If you look at the mean VASCO, that it is significantly similar for 12 months, and also mean MEPS score, which is also similar for the 12 months. Well, several studies have indicated that the leukocytes in the PRP have positive anti-infectious, immunoregulatory, and the angiogenesis effect, while some studies have proposed that the leukocyte should be withdrawn from the PRP, and leukocyte poor PRP are the ideal candidate for the lateral epicondylitis. Gautam et al., he compared the influence of the leukocyte poor PRP and the corticosteroid on the grip measure in the patient with the lateral epicondylitis. As a result of these effects, he concluded that the increasing the concentration of the leukocyte in the PRP can have a beneficial impact on the tendon healing in the long term instead of corticosteroids. Yeri Likaya M et al. Showed that the superiority was established for the either a single dose of the leukocyte poor PRP or the leukocyte rich PRP for the lateral epicondylitis. The study showed no significant difference in the short-term improvement in the pain in both the arms. However, significant improvement was seen in either of the groups regarding VAS and the MEPS score in the long term. And Montalvan et al. Found improvement in the pain score significantly at the 6th and 12th month in both the groups, but no significant difference was detected among the groups. There were limitations in our study. MRI should have been done pre and the post injection in the affected area for the objective radiological quantification of the improvement in the patients. And the small sample size and is a single center study with a short follow-up. Further studies with a large sample size involving the multi-center are needed to understand the effect of the preparation techniques and the method of the application of PRP in the long term. On conclusion, PRP injection are the safe and effective treatment method in the management of the patient with the lateral epicondylitis, irrespective of the concentration of the leukocyte present in them. And we have established that the concentration of the leukocyte did not play a role in altering the course of the treatment outcomes. Thank you.
Thank you. Any questions? Can you explain the double-blind pattern of the double-blind pattern of your study?
So in that
What do you mean
actually
that,
only I know about that, and we have 3 units in our hospital. So we
Right.
have told those who are using, because in our hospital our doctors are using PRP. So in lateral epicondylis tennis elbow patients, we used to do PRP, and we are following up only those patients on which even doctor doesn't know about this, that we are doing, and even patient doesn't know about
And
this.
doctor means
not me. I am doing this, but not other people.
Double blind, there are two people who are blind.
Yes, sir. Even doctor, someone, the doctor in other units, not in my.
In your study, double blind means two category of people should be blind.
Yeah.
One is who is blind first. One category is what who is blind.
So the
First is
patient, yeah.
He is always blind. Whenever
Yeah.
काम वाला लगाएंगे ज़्यादा. So one is patient.
Yes.
Who is second who is blind?
So we are providing to the doctors.
Either a doctor
Yeah.
can be blind.
So doctor,
or a evaluator can be blind.
so doctor, because we are providing.
A doctor is blind.
So because I am providing leukocyte rich or poor to the doctor, but he doesn't know about that. Yes.
And you have randomized your patients?
Yes, sir.
You don't need MRI for evaluation. You can use a musculoskeletal radiologist, and sonology will be a handy treatment.
Yes.
MRI becomes a difficult proposition for this.
For all the patient, we can't do that. So one was the monetary, financial.
Prefer that sonography is a preferred treatment.
Preferred
right now.
treatment, yes.
Right. Thank you.
Thank you.
Next one. I think Vikas. No, Mr. Ashish is there. Sorry. Please come.
Good afternoon, everyone. Myself, Dr. Ashish Kumar. My topic for paper presentation is results of ulnar nerve decompression for ulnar nerve neuritis. Brief introduction. It is the second most common nerve entrapment syndrome of the upper extremity after carpal tunnel syndrome, most commonly compressed in the cubital tunnel region at the elbow. The cubital tunnel region, it is formed medially by the medial epicondyle, laterally by the olecranon process of the ulna, and by the tendinous arch joining the humeral and ulnar heads of the flexor carpi ulnaris muscle. There is in patient there is change of sensation along the distribution of ulnar nerve in hand, produces numbness and paresthesia in the ring and little finger. There is weakness of intrinsic muscles of hand. There is partial clawing of hand and difficulty in pinching. Some causes and risk factors of ulnar neuritis. Traumatic causes, most commonly, the fracture of the medial epicondyle, the fracture dislocation of elbow, the direct injury on the medial side of the elbow, and cubitus valgus. Other causes, important causes like Hansen's disease and diabetes mellitus, and some rare causes like rheumatoid arthritis and collagen vascular disease. The aim and objective of this study is to determine the efficacy of decompression of the ulnar nerve in the treatment of ulnar neuritis. Material and methods. This study was conducted at the Department of Orthopedics, FH Medical College and Hospital, Agra. The patients complaining of numbness, paresthesia in little and ring finger, with or without compromise of the hand function, were included in the study. And a total of 15 patients of neural symptoms, which were not improved with conservative treatment for a period of 12 weeks, were taken in the study. Inclusion criteria, neural symptoms, duration 12 weeks, and exclusive ulnar nerve involvement. And exclusion criteria, direct penetrating trauma, any nerve pathology, or mononeuritis multiplex. Diagnostic criteria will be symptoms such as paresthesia and numbness and sensory loss, palpable ulnar nerve, features of ulnar clawing, Waterburn sign, presence of Tinel's sign around the elbow, results of a provocation by elbow flexion test, and Dellon's staging system. These are some pictures showing the swelling of over the medial epicondyle area due to thickening of the ulnar nerve. There is clawing of the little finger and Waterburn sign, that is the abduction of the little finger. Dellon's staging system for ulnar compression at the elbow, in mild, moderate, and severe. And the electrodiagnostic studies, pre and post-operative motor conduction velocity is recorded. The diagnostic criteria for ulnar neuritis is absolute conduction velocity if less than 50 milliseconds. Operative procedure done. All procedures were done under axillary block. Patient was in mid-prone, either in mid-prone or supination position. The part was repaired and medial epicondyle was palpated and cubital tunnel was opened by skin incision, and deroofing of all the tunnel tissue was done under microscope. An incision was given to the perineurium and epineurium to decrease the inflammatory compression in the axons. Drain was kept to relieve the edematous fluid. Skin was sutured and the hand was kept in elbow sling post-operatively. Post-operatively, we gave the patient antibiotics such amoxicillin and clavulanic acid for a period of 5 days, and the dressing was changed after 72 hours, and the drain was removed. These are some pictures showing the incision of the medial epicondyle and the surgical decompression of the ulnar nerve. Follow-up, post-operatively, assessment was done at 6 weeks and 3, 6, 9, 12, and 18 months following surgery in all patients. The minimum follow-up is 18 months and the maximum was 3 years. We encountered a few complications in some patients. We encountered superficial infection in 3 cases. The result, the recovery of pain is seen in first 24 hours in all cases. Sensory recovery for pin and cotton touch was seen within 4 to 6 weeks, while deep sensation for pin prick returned back in 6 to 8 weeks. The recovery of motor status took 24 to 54 weeks to recover completely. Total number of cases, we on the basis of medical research council grading, the muscle power was checked, and in 2 cases, from 1 by 5, it improved to 3 by 5, and in most of the cases, for power of 2 to 3 increased to 4 to 5, and completely improved to 5 in 4 cases. Conclusion, our study concludes that for all types of neuritic cases with sensory and motor symptoms of 12 weeks duration, which are not showing improvement with conservative treatment, must be undertaken for nerve decompression so as to prevent any occurrence of deformity. And it is a technically simple, safe, and effective method for treating ulnar neuritis with good results. Thank you.
Thank you. Questions? No. What is the duration of your study? No.
Sir, duration, it is a retrospective prospective study. So duration of study was mostly from taking from back, it does 3 years.
You have collected these cases in 3 years.
Yes. Before I came to that hospital, there was retrospective data and some data I took prospectively.
Right.
Yes, sir.
And how you confirmed your diagnosis in all these cases?
Sir, diagnosis was confirmed by assessing the patient, as in diagnosis by the symptoms of the patient, such as paresthesia and
You have taken your nerve connection velocity into account.
yes, 50,
right?
less than 50 millisecond.
Yeah,
Yes,
but
sir.
my question is, what's the final diagnosis? It's a nerve neuritis, it's a compression,
Yes, sir.
because you have gone for decompressive
Yes,
surgery.
decompression. Yes, sir.
So there may be other factors. So have you ruled out those factors there?
Yes, sir.
How?
Sir.
Because you have not mentioned anything in your study. You have just mentioned NCV is done.
Yes, sir.
That's confirmatory.
Yes, electromyography.
And you have done a microscopic release of
Yes,
the,
cubital tunnel. Yes, sir. The cubital retinaculum.
you're cutting over the epineurium.
Yeah, we also cut the epineurium and the perineurium.
What is the benefit of that?
Sir, to decrease the
Now, you
inflammatory
have done an
process.
open surgery, you have just done decompression, you have released the fascia there.
Yes, sir.
Then why cutting over the nerve with a microscope? उसकी जरूरत है इस केस में?
Sir, we did in mostly all the cases this thing.
Okay, thank you.
Okay. Thank you, sir.
Next.
So my topic is fibromyalgia, debilitating yet underdiagnosed entity. So as we all know, 60-70 of percent of people suffer from low backache in their lifetime, and out of these, 7 to 10% become chronic. These patients may or may not have structural cause of backache, and a large subset of these patients may have associated somatic, cognitive, and affective dysfunction, which are often overlooked and lead to misdiagnosis and treatment failure. As per literature, fibromyalgia contributes for significant number of chronic backache patients, but in clinical practice, it remains a diagnosis of exclusion in absence of definitive diagnostic workup. So, fibromyalgia is a medical term used currently for individuals with chronic widespread musculoskeletal pain for which no alternative cause can be ascertained. First, it was used by Sir William Govers, the term fibromyositis in 1904. But the current concept of fibromyalgia was established by Smith and Modosky in mid-1970. After this, in 1990, ACL classification criteria were laid down for research used to standardize the definition of fibromyalgia. Over a period of time, it was learned that the diagnosis of fibromyalgia by dichotomous criteria of ACR 1990 are not maybe erroneous. So it leads to the multicentric trial by Wolf et al. And that leads to the development of the case definition and the preliminary diagnostic criteria, that is ACR 2010 for the diagnosis of fibromyalgia. Since the publication of the ACR 2010 criteria, several studies have been performed with respect to validation of preliminary diagnostic criteria and development of the alternate criteria for the diagnosis of fibromyalgia. So I'm skipping this etiology and all. I'm coming to the study. So with this background, we evaluated chronic backache patients for the diagnosis of fibromyalgia by ACR 1990 and the ACR 2010 criteria to develop the simple and practical approach for the diagnosis of the fibromyalgia. So all patients with chronic backache, that is having more than 3 months of symptoms, were included. Most of the patients were between 20 to 50 years of age, including both genders. Exclusion criteria were the patient with no neuropathy, inflammatory arthritis, degenerative arthritis, post-traumatic back pain, post-hysterectomy, patient suffering from previous lumbar surgery, renal, hepatic, endocrine, cardiovascular, or respiratory disease, infection, whether local or systemic, and patients who have been already diagnosed with fibromyalgia were excluded. Detailed clinical, radiological, and laboratory evaluation was done to exclude secondary cause of chronic back pain, such as lumbar canal stenosis, spondylolisthesis, osteoporosis, and osteomalacia. So as we know, ACR 1990 criteria depends upon the fulfilling of the two conditions, that is the history of widespread pain that is lasting for more than 3 months, and the elicitation of the tender points, that is 11 or more out of these 18 criteria. And ACR 2010 criteria involves the ascertainment of the two things. First is a WPI, that is widespread pain index, and second is the symptom severity scale. And when the patient who satisfies the three diagnostic criteria, that is widespread pain index more than or equal to 7, along with symptom severity scale equal to or more than 5, this WPI 3 to 6, and symptom severity score more than 9. And second point is symptoms having lasting for more than 3 months. And the patient, third thing is patient does not have disorder that would otherwise explain this condition. So by this, we sum the widespread pain index and the symptom severity scale, and the widespread pain index, the summary of painful site out of the 19 predefined location, and it corresponds with the tender point criteria of the ACR 1990. The symptom severity scale score is a composite variable composed of physician graded cognitive symptoms, fatigue, unrefreshed sleep, and somatic symptom count. The combination of WPI and SS scale gives us the fibromyalgia severity score, which is also quantifying measure for the fibromyalgia severity. This FS score more than 12 confirms the diagnosis of fibromyalgia, provided the fulfillment of the diagnosis criteria, that is WPI more than or equal to 7, and SS score more than equal to 5, or WPI 3 to 6, and SS score more than 9. We evaluated 185 patients of chronic backache by ACR 1990 and ACR 2010 criteria, and average age of patients was 36.5 years, with majority of females. Average duration of symptoms were to 21.5 months, that is symptoms lasting for 3 months to up to 10 years. 126 patients diagnosed with a case of fibromyalgia by either ACR 1990 or the ACR 2010 criteria, and out of these 67 patients satisfied the ACR 1990 criteria, while 125 patients were complying with the ACR 2010 diagnostic criteria. Average FS score for fibromyalgia patients satisfying ACR 10 criteria was 19.8 plus minus 3.8, and the average FS score for the fibromyalgia patients satisfying ACR 1990 criteria was 21.4 plus minus 3.3, as compared to the 17.5 plus minus 3.3 for those not satisfying by the ACR 1990 criteria, but was diagnosed as by the ACR 10 criteria. So average tender point criteria count was 12.5 in ACR 1990 positive fibromyalgia patients, contrary to the 9.5 plus minus 3.7 among ACR 2010 positive fibromyalgia patients. So if you see the multiple somatic symptoms, so we found there was somatic symptoms as was shown by the 2010 criteria. There are around 41 symptoms which are often found in these patients with fibromyalgia, and when we evaluated it, we found the sleep disturbance was the present in approximately all patients of approximately all patients, and fatigue in 94.4%, and cognitive dysfunction was present in 93.6% of patients. Insomnia and walking with unrefreshed sleep was the commonest feature in a majority of patients. ACR 2010 criteria, when compared to the ACR 1990 as gold standard, showed sensitivity 98.5 and specificity 50% and 76.6% accuracy with likelihood ratio on 1.97. So low backache pain is amongst the most common reason for orthopedic neurology and pain clinics consultation, and some of these patients have chronic symptoms and are refractory to the treatment. The clinical assessment of such patients reveals presence of widespread musculoskeletal pain, fatigue, sleep disturbances, multitude of somatic symptoms. And these patients seek consultation from physician to general surgeon, gastroenterologist, neurologist, psychiatrist, and others. And fibromyalgia syndrome, in background, fibromyalgia syndrome is a chronic condition which undefined etiopathogenesis, which has prevalence of 2 to 4% of patient, and characterized by widespread musculoskeletal pain, sleep disturbances, and the variegated systemic symptoms. As such, there is no gold standard for the diagnosis of fibromyalgia, but for the long time, for ACR 1990 tender point criteria were used for diagnosis of fibromyalgia in many studies, but have limitation of expertise for tender point elicitation, subjective bias, and dichotomous nature. There is inherent problem in diagnosis of fibromyalgia among patients with generalized symptoms, as ACR 1990 criteria does not take into consideration into the cognitive, somatic, and the affective symptoms. So Yanmaz et al. Evaluated the reliability and validity of the Turkish version of these criteria, and evaluated 132 female patients who were newly diagnosed for fibromyalgia by using ACR 1990 criteria, and he concluded that the majority of patients who were diagnosed by 1990 criteria also satisfied 2010 modified ACR diagnostic criteria. In present study, also we found that 66 out of 67 patients who satisfied ACR 90 criteria were also satisfied the ACR 2010 criteria. So a systemic review done by Heman also showed.
Your conclusion now.
So, sir, conclusion is patient presenting with chronic widespread pain. If you even investigate those patients, they are having multitude of symptoms like fatigue, sleep disturbances, cognitive dysfunction, anxiety, depression, and most of the time we leave those symptoms. We always think the patient is functional, or we start giving them the painkillers. A lot of times we give them, and they are wandering around. If you ask them specifically, are you having any other problem? They will say, "Ha, sir, no, sir, nothing else." Then you ask, having any problem with sleep? Yes, we are having problem. Having any problem with ENT? Yes. Any gastrointestinal symptom? Yes. And when you start taking this tree, you come across the patient is a clear case of fibromyalgia. And if you use this criteria performa, you can immediately diagnose a case with fibromyalgia in the first go. After seeing these records, most times these patients are coming with the records, a lot of investigation. I've seen with the 10 years with this much book like the investigation. And if you investigate them, then they comes because there is no different diagnosis, but you use this criteria and you can diagnose that this is a patient with fibromyalgia. So last line, device fibromyalgia diagnostic criteria are simple and reproducible means of diagnosis of fibromyalgia, which leads to the better perspectives of addressing and managing the crippling conditions. So that is my message to the only 2-3 people audience.
Which criteria you will recommend now? Because you have said almost every case except one or two, you will diagnose with ACR 1990 and 2010.
Yes.
So which one you will
ACR
prefer?
2010 criteria.
Latest
Because this
one.
is specific and it's very easy to use. And now there are further revisions of these criteria like 2010-11, in which you can give questionnaire to the patient and he or she can herself or himself evaluate themselves. Now they have come 2016 revision that excludes the need of excluding other diagnosis for making diagnosis of fibromyalgia. So by using that 2016, there's a minor variation that this symptom severity scale like this 3 to 6. If they use 4 to 6, so if you use that, you can without excluding other causes, because this fibromyalgia sometimes coexists with the other condition like rheumatoid arthritis, chronic inflammatory diseases. They coexist. So you don't need to exclude those conditions, and immediately you can diagnose with this. So my message is key to diagnose this chronic backache patient for fibromyalgia in first go.
Then how will you manage these patients, sir?
Sir, it involves the usage of pharmacological and non-pharmacological means, and non-pharmacological means also have a very good role. Pharmacology means we use duloxetine, amitriptyline, pregabalin, and painkillers. If you don't use normal NSAIDs because they don't work. Specifically, these patients respond to tramadol. And non-pharmacology means sleep hygiene. I specifically tell this patient about you go to sleep whether your work is done or not. Don't bother about the household work. Go at particular time, you go at 9 or 10, you go. Don't see mobiles, TV. Keep a cool, calm room and sleep. Try to sleep. Second thing is meditation. I specifically have 10 minutes meditation. And if you want to do more, you are free. But from my side, you have to do this 10 minutes normal exercises in the form of walking and stretching.
What about pharmacological medicine?
Pharmacological pregabalin, duloxetine, amitriptyline, and tramadol. But not in all cases. We titrate the patient accordingly.
Thank you.
I've published also in IGO.
That's great. Thank you. Dr. Raghav. Everybody finished?
But there will be issue for your certificate.
No, we are ready to listen to you.
So I'll be presenting a case report of a long head of triceps transfer to achieve the active elbow flexion. So loss of active elbow flexion is disabling for any patient, and it mostly occurs after brachial plexus injury or any anterior elbow trauma, and it leads to irreplaceable damage of biceps and brachialis muscle. There have been several procedures which have been commonly used, but there are more promising results which has been described by the procedure of long head of triceps transfer to achieve this active elbow flexion. So I'll quickly run through the slide. A 33-year-old male car driver came to the OPD with a complaint of inability to flex his right elbow since 1 year. He was apparently all right 1 year back when he had an history of RTA where he was diagnosed with a grade 2 open distal and radius fracture and a decloving injury over the anterior aspect of the elbow. And he was treated with KYS for the distal radius and debridement for the with SSG for the compound defect over the anterior elbow. And his right limb was splinted in a long arm posterior splint with elbow in extension for a period of 2 months. But unfortunately, due to COVID, he did not come for the follow up for 1 year. So after 2 months, the KYs and splint was removed somewhere nearby hospital, and graft uptake was 98%. Since then, he was unable to flex his right elbow, and there was a deformity at his right wrist, and there was clawing of the fingers. And disability was he is unable to do his job as a driver. Activities of daily living like combing hair, eating, lifting weights, all were limited. And there was no history of any massage, coac treatment, past illness, and rest all was non-significant. On physical examination, nothing significant. So when we come to the local examination, the attitude, the shoulder was adducted with elbow full extension. Carrying angle could not be commented as he had a deformity over the forearm. Inspection, the deltoid west string was not present. In the elbow, there was an irregular size puckered scar present over the anterior aspect of the elbow. Elbow flexion crease was absent. The biceps tendon extensor and flexor origin mass was not visible. And from the lateral side, a prominence was seen distally to the lateral epicondyle. Biceps wasting was seen, and biceps muscle and common flexor origin was wasting was seen. And so yeah. And in the forearm, 5 centimeter long curved scar was seen on the distal third of the forearm over the ulnar-volar aspect. And in wrist, deformity was seen with ulnar head undue prominence. And hand no wasting was noted, and extension and the clawing of the fingers were noted. In the shoulder, there was no wasting, and deltoid regimen badge sign was negative.
You can go to your operative procedure, what you have done.
Okay, sir. Just I would like to show the clinical photos. So, and in shoulder, everything was fine. In the elbow, passively full range was there. Active flexion was 0. And in the forearm, there was a pronation was lateral limited and supination was 0. So what we did was we harvested the middle half of the long head of a triceps muscle and we attached it to the anterior aspect of the proximal ulnar distal to the coronoid process through a subcutaneous tunnel from posterior to anterior from the medial side of the elbow. And it was fixed through a Ethibond suture and 5 mm suture anchor. So the patient was supine with general anesthesia, long posterior approach of the humerus arm was taken, and the triceps long head was isolated. Subcutaneous tunnel was made, and through the posterior approach of the ulna, the proximal triangular part of the proximal ulna was exposed, and the medial anterior border of the triangle of proximal ulna, there the suture anchor and the graft was fixed in 110 degrees of elbow flexion. So these were the intro of photos. And the patient was immobilized in long and splint in 110-degree flexion for 6 weeks. Throughout this period, all the active movements, ROM was encouraged and no weightlifting was advised. After 6 weeks, hinged elbow brace with progressive elbow extension was encouraged. And from 6 weeks to 3 months, active physical therapy with active and passive elbow flexion as tolerated, adjusting the hinged elbow brace periodically, and active elbow extension was encouraged. Functional outcome 3 months post-operatively, independent elbow flexion and extension was achieved with power of both flexion and extension muscle grade MRC grade 4, and active elbow flexion of arc of around 100 degrees was achieved, and mean flexion strength of 3.3 kgs at 90 degrees of elbow flexion was achieved. So discussion, there is only 3 to 4 articles on this, where it has showed a very good, reasonable post-operative elbow flexion arc with no very less loss of elbow extension as compared to the total triceps transfer, which on which there are relatively more clinical studies. So hereby I conclude that the restoration of elbow flexion is very important, as it leads to significant poor outcomes if not treated well. And since the patient was 1 year old, so nerve transfers or any nerve transfers would have not helped anything. Since the target muscle was atrophied or destroyed, actually we can transfer that long head to either the distal biceps or to the radial tuberosity or to the ulna. So we couldn't do it to the distal biceps as it was totally atrophied. Radius we could not do because there was a posterior medial radial head dislocation. So we went with the approach to fix it to the proximal ulna. So and complete triceps transfer is not advisable because it leads to greater deficits with long-term flexion contractures of the elbow. So till date, no significant, no much bigger significant complications has been noted with long head of triceps transfer. Those clinical evidence is limited. So these are my references. Thank you.
Any questions?
How you increase the length of triceps?
Sir, we didn't have to do that because there was a considerable, there was a length. Actually, from when we take it out from the olecranon, we have to even go further and include the fascia as well. So intraoperatively, we didn't feel the need to do that. Or else, in that cases, we can go for palmaris longus grafts. That is what I studied. I'll just refer, sir, once again.
Any other transfer you could have considered here?
Yes, latissimus dorsi and pectoralis major transfers leads to good muscle power, but it's technically demanding larger surgeries, and it might lead to destabilization of the shoulders as a complication. So we didn't go for that. And then stainless flexuroplasty is there, where we can shift the origin of the flexor pronator mass anteriorly 5 centimeters above the medial epicondyle to the anterior humerus.
That
So
would have
these are
been easier, no? Shifting this mass pronator teres proximally would have been easier part.
Yes, sir, but the disadvantages of this procedure is it leads to weakened power, sir, weak power. And it might also lead to, due to, if not done technically correct, then it might lead to pronation deformities. Already the patient is in pronation deformity.
Why you have chosen specifically this long head of triceps? The reason is
Because
how you have
it has
excluded
promising
others.
results, and it is technically easier, sir. And no significant disadvantages.
Sure, that's great.
Thanks
Thank
a
you.
lot, sir.
I thank all the speakers as well as the listeners.
Thank you, everyone.
Thank you very much.
Thank you,
Thank
all
you.
the faculties, the respective. भैया अभी जो मैंने प्रेजेंटेशन दिया सिर्फ एक फोटो ले पाऊंगा क्या या एक छोटा अगर इसमें आप चालू करोगे तो मैं जरा एक वीडियो ले पाऊंगा क्या क्योंकि सर्टिफिकेट के लिए वो दिखाना होगा कि मैंने प्रेजेंट किया हाँ ठीक है अगर वीडियो चालू हो सकता है तो मैं 5 सेकंड का ले लेता हूँ 5-10 सेकंड अगर वही वापस वीडियो चालू हो सकता है जो मैंने प्रेजेंटेशन दिया अभी फोटो नहीं लेना है अभी जो मैंने किया था ना फोटो भी नहीं लेता हूँ मैं आपका प्रेजेंटेशन नहीं कर देता हूँ आप फोटो ले वीडियो नहीं वैसे नहीं वैसे वैसे तो कोई भी फोटो ले लेगा ना वैसे नहीं ये ऑनलाइन जा रहा होगा ना तो ऑनलाइन मिल जाएगा ना अगर मैं स्क्रीन रिकॉर्डिंग कर लूंगा
एकदम पता नहीं। हेलो रुपेश भाई डाटा उठा लेना है मेरे को।